You cannot start your video because the host has disabled it. এটা তো অন হয়ে গেছে। এটা মিউট করা হয়েছে, এটা মিউটটাকে কাটতে হবে না, তবে তো আনমিউট হবে। এটা হলে মিউট, এটা হলে এখন আনমিউট আছে।
Good evening, Dr. Urmi. How are you?
I'm fine. How are you doing?
Very good, thank you.
Good evening, everyone.
Good evening, sir. Good evening. How are you?
Good evening, everyone.
Yeah, hello, good evening, Dr. Sajna. How are you?
I'm very well, thank you so much. How are you, Dr. Rao?
Very good. Thank you all for coming over here today.
Good evening, everyone.
Yeah, hello, Mansi. Good evening.
Hello, sir. Good evening. Thank you, everyone, for taking out time and joining us here.
Good evening, Mansi. Good evening, Dr. Sajna.
Good evening, Dr. Sajna.
Dr. Sanjeev. Good evening, Dr. Anuradha. How are you doing?
I'm doing good. How are you all?
Very well.
Okay. So the program, so Mansi, the program starts at 6 o'clock and it's the first session is pathology beyond IHC, right?
Right, sir. The first session is pathology beyond IHC on
Right.
molecular markers and starts at 6.
And chairpersons are who all?
Persons are Dr. Sanjeev Kathuria and Dr. Urmi Mukherjee and you, sir.
Okay, fine. So then I'll request Dr. Sanjeev and Dr. Urmi to take over the whole thing. I'm just there. So maybe you can introduce and then call the speakers one by one. I think that will be fine. They have the whole program, I hope.
Yeah, we have the
I have
program.
the program.
Okay, great.
I think the third session panel discussion will be taken over by the moderator. We have to just call the moderator.
Moderator and the moderator.
Dr. Anita Ramesh from Chennai.
Right. And then
Right, sir. Right.
And all the panelists are there. All the slides are in, Mansi. Hello. Yeah.
So people are still joining in. I don't think we have all of them about right now.
Yeah, but our the team, the organizers team, the slides of the first speaker, Garima or somebody will, Rohit or somebody will tell about the slides part. Who's from the horizon? Can you just check, Mansi, all the slides because just we have.
So I think Rohit and Garima are here. So do you have the slides for the first speaker, Dr. Mosmi?
Yes, ma'am, I have slides.
Okay, fine. So just remind Dr. Mosmi so that she's here.
Garima, can you just make a call with Dr. Mosmi? Suryavanshi.
Yes, ma'am, she will join in 5 minutes, ma'am.
Okay. All right.
Dr. Urmi, I will start I will invite the faculty and delegates and start the first session. That is molecular markers in lung cancers by Mosmi Suryavanshi. When that is completed, then for the second, that debate on liquid biopsy, you can call upon for the motion against the motion.
Right. Okay. That's fine.
Garima, can you also contact Dr. Parneet Singh? Because he is also one of the session coordinator, but I don't see him participate in it.
Ma'am, sir is joining, ma'am.
So the recording will be done by, the recording of the session is being done, controlled by them. Who is doing the recording? Garima?
Rohit, Garima, are you there? Who will be taking care of the recording of the session?
Ma'am, meeting ends more, Rohit sir will coordinate their recording, ma'am.
Yes, ma'am. Yes, ma'am.
So you will be starting the recording, Rohit?
Ma'am, now?
No, whenever
No,
it's
as soon as we start the session.
Yes, ma'am. Yes, ma'am.
okay. Fine. So all the speakers, all the slides are in, right?
So the speakers are still joining in, sir. We don't have all the speakers.
Slides are all in.
Do you have all the slides with you, Garima? All the presentations?
No, ma'am. No, ma'am.
You don't have?
I have my slides. I'll be operating from my website.
Okay.
Okay, okay.
Against is Dr. Bhattacharya, right?
And Dr. Anita's slides, Karima?
सर मेरी ना बात हो गई है मैम से, मैम ना खुद शेयर करेंगे स्लाइड.
Okay, fine. ठीक है. And then the next session the second session is Dr. Chaitanyanand Kopikar.
सर मेरी बात हो गई है सर, सबसे मैंने कनेक्ट कर लिया सर.
Okay, सबकी slides हैं. Good. Okay. Chairpersons are also in. All the 3 chairpersons. Are they in? In meaning they have confirmed that they'll be joining?
Yes, sir.
Okay. So we should start on time, Mansi.
Right, sir.
Right?
Yes, sir. Hello, good morning, sir. Good evening, sir. Dr. Parneet, sir.
Yeah, good evening, Parneet. How are you?
Good evening, Dr. Parneet.
Good evening, ma'am. Good evening.
I think recording is already started. I think we should delete this recording. We should do it exactly at 6 o'clock when we start. Rohit, you're doing that?
Yes, sir.
Yeah, the recording you already started, it indicates.
Now started, sir.
No, I said this recording, this particular thing need not be recorded. You must only record the deliberations.
Okay, sir. Okay.
Right. When the chair, the coordinator starts, that's the time. It's sharp at 6 o'clock.
Dr. Parneet.
Yes, ma'am.
So you will be starting the session, the
Yes.
first session, the pathology beyond IHC session.
Yeah.
Okay. So we
Yeah.
have all the chairpersons here.
Hello, sir. आपने उसको फोन करो.
Are the questions be taken after each talk or at the end of the session?
And we would prefer it at the end of the session, ma'am.
Okay, right.
Because that will depend upon the time left also.
Yes.
Okay.
Is Dr. Bhattacharya there?
And sir will join in 5 to 7 minutes.
Okay.
Dr. Mosmi has joined.
Yes,
Good
sir.
evening, everybody.
Good evening. Good
Good
evening.
evening, Dr. Yes.
Good evening, ma'am. Welcome.
Good evening.
शुरू तो 10 मिनट
I would request everyone to keep their mics muted.
This video and this voice control will be through the host, or we can control it from our end?
It's with the host and the co-host. So the technical team is going to unmute as soon as the person is going to speak.
Okay. Today's session is the first session and also first session of the conclave. See, in this 1 hour session, we have got 3 important topics lined up. First, there is a talk by Dr. PCC2021 lung cancers, followed by interesting debate on anything liquid biopsy from the motion and against the motion. August to August faculty to faculty members of this faculty members by Dr. G.S. against the interesting debate. Interesting debate.
Dr. Moshmi, good evening.
Good evening.
Yeah, Dr. Angarao here. How are you?
Good evening, sir.
Nice to see you here. You are the opening batswoman.
Yes, yes, sir.
So what is the control time? And the timer is there?
Yeah, I can't see.
Yes, sir. Yes, sir. Time is.
Okay, fine. So when are we there? Kindly announce and start.
I think it's already 6.
Yeah. So, so let me begin and then hand you over to Dr. Mansi. I think each and every one of you, very, very warm welcome to you. And then we're very happy to host this conference. And we started off this thinking about this conference about 3.5 months ago, and it has taken a very good shape. We wanted to have the primary care physicians and all the disciplines of the oncologists and everyone else in this. And we have succeeded, to even our surprise, to register about 8,000 people. I mean, that's a huge number. And all of them are distributed in various halls. And here we can only see the participants, but they're all listening to it. So hopefully that will be very good to see. So I'll hand you over to Dr. Mansi conduct of this session.
Yes. Hi, Dr. Rangarao sir. I'll be handling the session in the beginning.
Okay. Yeah, Dr. Parneet, please.
So, good evening, everyone, and welcome. I welcome you all to our first Paras Cancer Conclave. I am Dr. Parneet Singh. I am currently working as a radiation oncologist at Paras Panchkula. And I would like to welcome you all for this academic feast spread over the next 3 days, that is Friday, Saturday, and Sunday. And we hope to see you on all the 3 days. We are trying that our small endeavor helps us to redefine cancer care for the next decade. Without further ado, I'd like to introduce the chairpersons for the session. First, I'd like to introduce Dr. Urmi Mukherjee. She is currently the director histopathology at Max Hospital, Saket, where I had the privilege of working with her when I was at Max Saket in radiation oncology. Dr. Urmi, please, I welcome you. Hello, Dr. Urmi. Dr. Urmi.
I think she's.
Can you hear me?
Dr.
Hello.
Dr.
Hello.
Urmi, can you hear me?
Can you hear me?
Yes, ma'am. Yes, yes. I welcome you, ma'am, to the first Paras Cancer Conclave, ma'am.
Thank you so much.
Then my next chairperson is Dr. Sanjeev Kathuria. He's a consultant pathologist at Onquest Labs, which I have the privilege of working at Paras. And my third chairperson for the day is Dr. Rangarao sir. He needs no introduction. He's the director cancer care at Paras Hospitals. And he's also achieved he has written many papers published in national and international journals. Also, he's received many awards, and he started cancer cancer centers at a lot of hospitals in Delhi and around. So I welcome you, Dr. Rangarao sir.
Thank you very much.
I would like you to first introduce the first speaker for the day. That is Dr. Maushmi Shuravanshi about her lecture. Thank you, Dr. Rangarao.
I'll request Dr. Katuria to do the honors, please.
Good evening, everyone. I welcome all the faculty members and delegates for today's first session. This is the first session of Paras Cancer Conclave 21 in Hall C. And during this 1 hour, we have got 3 important topics lined up. First is the talk by Dr. Maushmi Shuravanshi. It is being followed by a debate on liquid biopsy for and against the motion. Dr. Maushmi Shuravanshi, we all know, she is senior consultant in molecular diagnostics in Rajiv Gandhi Cancer Institute. My only submission to the faculty members will be to stick to the timings, because after this 1 hour session, it is followed by another important sessions in same hall C. So without wasting any more time, I call upon Dr. Maushmi to start her talk.
Good evening, everybody. I'd like to start sharing my screen, but you'll have to allow me to share. So please allow me to share my screen.
I'm already allowed.
No, but you'll have to stop sharing so that I can start sharing.
Ma'am, please start.
Can you see my screen?
Yes, ma'am. Please start a slideshow.
Yeah. Okay, good evening, everybody. I'm Dr. Maushmi Shuravanshi from Rajiv Gandhi Cancer Institute and Research Center. So I'll be speaking about molecular markers in lung cancer, methodology, and reliability. So what is the best way to treat a patient with lung cancer? First and foremost is to make an accurate and precise pathological and molecular diagnosis. And then, of course, is the timely initiation of effective therapy. And then, of course, the accessibility of effective therapies. But if you look at this paradigm, the most important thing is to make an accurate and precise molecular and pathological diagnosis. So for this, molecular testing and pathological testing is very important. So lung cancer has seen a paradigm shift. from just being called small cell and non-small cell to being subdivided in the non-small cell category into squamous and adenocarcinoma and other subtypes, and the expanding number of adenocarcinoma cases. In fact, previously most of the cases were called as squamous cell carcinoma. And then in adenocarcinoma, there are many molecular subtypes, and each of them have a separate targeted therapy. So we also have molecular subtypes for squamous cell carcinoma, but unfortunately till now, barring the FGFR, nothing seems to be coming up in the near future. But you can never say never. We will have therapies for squamous cell carcinoma also. So in lung cancer, we have two types of therapies. One is the molecular therapy and the other is the immunotherapy. So in the molecular therapy, there are targeted therapies against the mutations like EGFR, BRAF or HER2. Then it could be against the fusion products like ALK, ROS, RET, NTRK, NRG1, or it could be MET skipping mutation or over amplification of FGFR1, MET, EGFR or HER2. And for the immunotherapy, there are biomarkers like PDL1, which is not a very perfect biomarker, but this is what we have till now. And then there are upcoming biomarkers like tumor mutation burden, and MSI, of course, is an agnostic biomarker, but still has a limited role in lung cancer. And about the molecular markers, most of them are mutually exclusive. If you have one of the markers, the other is unlikely to be found. So this landscape, as I already mentioned, is expanding and it's very complex. And we have first generation, second generation, and third generation new drugs coming up almost every second month. So we have to keep a tap on this. So whatever I'm telling you is what is latest till now. So what are the testing approaches in lung cancer? And this I'm specifically referring to adenocarcinoma lung or lung cancer NOS. So then first we do a basic IHC, which should not be very extensive. It should include maybe a marker like TTF1 or P40 or P63 to tell it is an adeno or a squamous carcinoma, and also a PDL1 IHC. Though this is not used initially, but since it's a IHC based test, it has to be done initially along with the diagnostic basic IHC. And then there are two approaches. One could be a single gene testing approach, or the other could be a multiplex testing approach. In single gene approach, and it is usually single genes are tested, and it depends on the institutional policy, and there are many factors like cost which have to be taken into consideration. And for that, usually EGFR, ALK and ROS are tested in most of the institution, but it is good to include BRAF. But then in multiplex testing, all the remaining molecular markers along with the ones I have mentioned are tested together. And then it is usually done by NGS, and NGS is mostly tissue based, but liquid based NGS could also be done. So this is a comparison between advantages of single versus multi-gene. But of course, as we are moving towards more and more gene, it makes more sense, and it is also becoming more financially viable to do a multi-gene panel and look at all the complex pathways which are happening in one go. So these are the single gene marker which I have already mentioned. So coming to the EGFR mutations first, and I think we all know that most of the mutations which are druggable are in the tyrosine kinase domain, and these range from exon 18 to 21, and the commonest one is deletion 19 and L858R. And in our Asian population, the EGFR incidence of EGFR mutations is quite high, ranging from 30 to 50% in countries like Vietnam, and but in Western world it is hardly 10 to 15%. And there are various modalities to check EGFR mutations, and if you're doing a single gene testing, it makes more sense to go for a RT-PCR based technology, and if you're doing a liquid biopsy, it makes sense either to go for a digital PCR, which is more sensitive, or NGS like technology. And if you are including EGFR in a complex multi-gene testing, then NGS is the method of choice. So just to mention about liquid biopsy, since there is approval only till now for liquid biopsy in EGFR testing. So liquid biopsy, as we all know, has many obvious advantages. It is less invasive and also covers the heterogeneity of the tumor, which is missed in the tissue biopsy. And for now, as per the guidelines, we can use liquid biopsy when we already have a tissue diagnosis of malignancy, and as well as in the cases of resistant mutations. So when approaching a liquid biopsy, there can be two types of approaches. One is the targeted approach, where we are just looking at one gene, maybe EGFR in lung cancer, or maybe KRAS and RAS in colon cancer. And or it could be an untargeted approach, where we are looking at multiple genes in one go, and not only the mutation but fusions and copy number also. And for a single gene targeted approach, usually instruments like COBAS, TheraScreen, or digital droplet PCR, depending on the sensitivity, can be used. And for the untargeted approach, we need next generation sequencing instruments. So what is better, and what is the concordance? Liquid biopsy and tissue biopsies have shown in various studies to have very good concordance, ranging from maybe 90 to 95%. And I think following my lecture, there is a debate and about what is better, tissue or liquid biopsy. But if you just look at the figures and the data, it says that the synergy between tissue and liquid biopsy, if you combine them, you can pick up a lot more number of patients than doing each one of them separately. So usually liquid biopsy is employed for T790M mutation detection, but now, since we have multiple mechanisms of resistance to first line osimertinib and second line osimertinib, it makes more sense to do a NGS for liquid biopsy or tissue biopsy. Then coming to EML ALK, ALK is a fusion which we are looking for, and it has multiple partners, and ALK is the constant partner, but there can be other partners. And then there are various methods by which we can pick up these fusions. The commonest and the most one which is used is the IHC. Then we can do a FISH testing also, or look for the partners by RT-PCR or NGS technology. So this is IHC, showing strong granular cytoplasmic staining. And then there are two clones which are very important and which have been approved. One is the D5 F3 and F5A4 ALK clones, which are approved. But you also have to keep in mind that ALK IHC can be negative in bone biopsy, and in those cases it makes more sense to go for a FISH test if your IHC is negative. So these are your FISH ALK IHC. There you can also see polysomy in this figure, which can be a cause of resistance to the drugs. And sometimes there are single signals which may be misinterpreted as falsely negative, but they are actually positive. So those are the things which you need to keep in mind. Then there is ROS. This is again a fusion abnormality, and where the ROS is the constant partner and the commonest is the CD74 partner. And now, since we are seeing patients who have had treatment for ROS a long time, we are also seeing ROS resistant mutation, and amongst them G2032R is the commonest one. So again, we can check ROS fusions by FISH, RT-PCR based method, NGS or IHC. IHC has good sensitivity but less specificity. The approved clone is only one so far, D4, D6, but we are also having very good publications about the new clone SP383, which is from Ventana. The previous one is from Cell Signaling. And then again, it can also be done by FISH and NGS, of course. Then there are emerging biomarkers like RET fusion, MET skipping, and NTRK gene fusions. The drugs for these have already been approved. First is the RET one. It is again the fusion. It is also seen in your papillary carcinoma, but 1 to 2% of your non-squamous lung cancers have RET fusions. Most of these cases are detected by RNA-based NGS technologies, which are the best technologies to detect them, but they can also be seen by FISH or maybe DNA NGS testing. And the commonest partner is KIF5B. Then is the MET exon skipping mutation. This is found in around 3 to 4% of non-squamous cell lung cancer, and commonly seen in sarcomatoid cancers, but our own institutional experience has not been like that. But as per it is reported, it is like that. So the best methodology would be to look at these mutations at the RNA NGS level by looking at a fusion product of exon 13 and exon 14. Because of the mutation, the intervening exon 14 is skipped, and we have a product which can be seen in the NGS. But these mutations can also be checked in DNA. The sensitivity is more if you have a DNA NGS along with the RNA NGS. So that is the best way to do it. So then coming to the NTRK fusion. So this is an agnostic marker across so many tumors of the body. So again, we have NTRK 1, 2, 3, and there are various modalities for testing. It could be IHC, RNA, DNA based NGS, or FISH, or RT-PCR. IHC, the NTRK1 is not picked up that well. FISH, NTRK3 is not picked up that well, and DNA is NGS is also not that good because there are huge intronic regions. So the best method is RNA based NGS technology for detecting NTRK fusions. And I think that the time doesn't allow me to go beyond that. Yeah, I'll just finish it. So the dilemma of PDL1 IHC testing. So this is also very complex. So we have 5 antibodies, 2 immunosterin platforms. One is Ventana and one is Deco, on which they are tested. And there are different cutoffs for different trials. And then there are different scoring systems, some scoring only the tumor cells, some scoring the immune cells, and some having a combined tumor and immune cell score. So, and you can see here, this is one particular case with different antibodies, and the staining intensity is different. So that is the dilemma. So whenever you're following a particular trial, you need to use that particular clone, that particular platform on which, and that particular cutoff for PDL1 if you're going to decide on the immunotherapy. So coming to the new biomarkers, most of them have been listed before also, but we are very soon going to have a biomarker for KRAS 12C mutation, so which is common in lung cancer, and NRG1. And in fact, this is not included for now in most of the NGS panel in most of the labs. So this it is found in the bronchoalveolar type adenocarcinoma. Then MSI and TMB are agnostic markers across all the cancers. MSI is very rarely deficient or
you can sum it up, please, because others topics will get delayed otherwise.
This is my last slide. So to conclude, primary and metastatic tumors are equally important. They can be equally suitable. Then PDL expression must be checked in all cases of non-small cell lung cancer, and you should wait for the molecular testing results before you actually jump to a high PDL1, because your ROS positive patients can have a PDL1 of maybe 90 or 100%. And broad NGS testing panels should be encouraged. And with that, I would like to thank you for the patient listening.
Thank you, Dr. Masmi, covering the vast subject in such a short duration. I know it's very difficult to cover such a vast topic in just 10 minutes, but you gave a very nice talk. Now, Dr. Urmi, please welcome.
The next is a debate on liquid biopsy, a promising tool for the new decade. And I invite Dr. Anuradha Chaugule to speak for the motion. Dr. Anuradha, please.
Yeah, thank you, everyone. Today, I'll be debating against my mentor, Dr. G.S. Bhattacharya. Sorry, sir, for that. Sir, can you see my slides?
Yeah, we can.
Yeah, I hope it is in the Zoom mode. Yeah, that's it.
Please start.
Yeah. So like you say, the charity begins at home. For the FFP samples, I can say the quality of the samples begins from the from the operation theater, to have the right tissue, right time of fixation, and the right type of formalin to be used is very important and very critical in the FFP samples. So, and this is the era of genetic signatures. So based on this diagnosis, we have to go further. Coming to the liquid biopsy, it's not a new concept. It has been, as you can see, the various timeline right from 1948 to 2019, we have progressed. And today, from the single gene EGFR testing on the liquid biopsy for monitoring as well as for the as a predictive marker, we can have a big number of panel, multi-gene panel on the NGS as well. So what is exactly like, because in lung tissue is an issue, so heterogeneity is a very important factor which plays an important role for the false negative or the false positive result. But at the same time, you can see that the liquid biopsy, which is a true representative for the normal as well as the tumor tissue. So what are the cons of, like, what can the tissue be, why the tissue, will the tissue be replaced by liquid biopsy? Yes, because there are certain factors which has to be taken into consideration regarding the tissue biopsy. That is it has a identification of tumor tissue of predictive markers which can face several biological and technological fields in the lung cancer. Inter and intra tumor heterogeneity plays an important role to guide clinical decision. There are a lot of complications associated with the invasive procedures. Therefore, there is a which has been limited by the tumor accessibility. There is a poor performance status in the non-small lung cancer because of the limited role of the uncomfortable interventional biopsy procedure. And to say that there are high levels of C2T or G2A transversions in the really 1 to 25% allele frequency range, which can lead to the false positive results for the molecular assay. There was an IRESA study which gave a very high positive result in the liquid biopsy, and then it was approved for the use of cfDNA for the EGFR mutation analysis. So what are the advantage of liquid biopsy? Minimal invasive, easy to obtain from biofluids, less costly, short processing time, low to failure rate, high tolerance during the treatment, determination of tumor heterogeneity, and easy monitoring of treatment for the treatment response. But at the same time, if you go to see, there are a lot of drawbacks in the tissue biopsy: invasive and high cost, not easy to obtain from some organs, long processing time, evaluation of tissue limited heterogeneity, difficult to tolerate during illness, and difficulty in monitoring of the treatment response. So here is the Garden 360, which is the first FDA approved cfDNA panel with the 80 genes. And how do you treat at the speed of cancer? And here is the answer, that the answers are in our blood. So this is how there was a Garden 360 first FDA approved, but as of today, there is no FDA approved test for the tumor tissue biopsy for a bigger panel. So multiple tissue biopsy is not always feasible, but as you can see over here, you can get the different codes which can be intra and inter-tumor heterogeneity. But yes, the first liquid biopsy test was approved, and we can see this is an era of mutation testing in the non-small cell lung cancer. So this was our first paper of validation of liquid biopsy, where we did 132 paired samples, and we got a very high sensitivity and specificity and accuracy as well, which was very much expected in these samples because of our meticulous study in the cfDNA extraction methodology. So going ahead, it's not only the plasma, but you can also have the other than plasma liquid biopsy fluids like CSF, effusion fluid, pleural fluid, ascitic fluid, pericardial fluids, and so on. And it has shown in this study, it was shown that the rate of detection of EGFR T790 mutation resistant mutant was very high, and the cfDNA obtained from these body fluid other than plasma can be used for the detection of EGFR mutation, and that the mutation status may be useful as a predictor of the response of TKI. Other than that, there was an aura study where it was said that for the recurrence of tissue for the in the first line resistant patient, you can look for the T790 mutation with the cfDNA, and if it was positive, we could easily go for the osimertinib treatment. But if it was negative, then we have to go for the chemotherapy. But again, the negative cfDNA doesn't mean that it is true negative. Then we have to go back to the tissue biopsy testing. So for the tissue biopsy in the clinic, we have to patiently wait because it takes a longer time than the liquid biopsy, because there is a huge procedure for this. And here you can see, you can very well avoid these type of tumor procedures, and you can easily bypass these steps, like from the pulmonologist getting the tissue through bronchoscopy, or from the surgeons getting the tissue, and then it goes for the processing into the pathology lab, and then for the molecular diagnostic test. But if you bypass this, you can straightway send the samples for the molecular lab, and this reduces the turnaround time. So in the ASCO 2016, you can say the liquid biopsy, it was said that liquid biopsy may help getting good treatment decision for the patients with the advanced solid tumors. So here are the potential applications. It can be detected in the early stage disease. We can have the variant allele frequency at a very high rate compared to tumor biopsies, and it can be used in the advanced stage for the treatment selection, risk stratification, response assessment, resistance monitoring, treatment selection, and so on and so forth. As you can see over here in the same slide, I have elaborated the risk stratification, pre-treatment plasma ctDNA assessment, high ctDNA levels, more intensive therapy, low ctDNA levels, less intensive therapy, response assessment, pre-treatment plasma ctDNA assessment. And you can see over here, on treatment with plasma ctDNA assessment, you can have a various types of treatments, and you can get the less continue as a less intensive therapy, and you can change the treatment to more intensive therapy, or you can change treatment to more intensive therapy. For the resistance monitoring also, it can be used for the serial monitoring at various time of intervals. So these are the various publications which are coming up, which says that how important it is the liquid biopsy to do in the clinic as well as at the research. So early prediction of resistant TKI inhibitors. Then the same, one of the important paper was that the capture-based targeted ultra-deep sequencing the paired tissue and plasma sample demonstrated that differential subclonal ctDNA releasing has a capability in advanced lung cancer. And another is the detection of MRD using ctDNA in lung. So these are the current evidence and future directions for the liquid biopsy. And here you can see there's the escalating graph of the number of publications coming up for the liquid biopsy into the clinic as well as into the research. So this is still the tissue biopsy, I can say, still remains a gold standard. But yes, we can always have a monitoring with the liquid biopsy testing. But as I can say over here, we don't know which is the showing a very good testing, whether the liquid biopsy or tissue biopsy, because every biopsy methodology or the tissue for the liquid biopsy as well as tissue, it has its own limitations, and it has also the advantage and disadvantage. So we have to decide whether we should go for the tissue biopsy or for the liquid biopsy, depending upon the patient's history, whether it is at the baseline or at the recurrence or it is at the relapse. So in order to avoid the invasive procedures. And I will just like to show one of the last slide where we need to meticulously have the cfDNA extraction. We have to measure the acceptable range, which may be from 140 to 180. But out of this cfDNA size, we have to look for the ctDNA size, which will be around 120 to 130. The concentration should be around 25 to 30 nanogram, and the library concentration will vary as per the instruction which kit you are using. And the coverage for the NGS has to be between 10,000x and to 15,000x. And we need to do a meticulous quality check at every step, right from the before the library preparation and after the library preparation. And we need to see whether they fall into within the range of T7 between the amplicon size. And we need at the base line, when we extract, we need to see the peak, whether it has cfDNA as well, and we need to quantitate what is the ctDNA peak as well. So we need to look whether there is no admixture of the normal normal DNA into this sample. So depending, there are various extraction methodologies are available, and we need to compare. This was one of the tests we did in our lab, and we saw to it that NextPrep, which is there, which has the highest, which can extract the highest yield of cfDNA essential. So this was my last slide, and I can share, give it to Dr. Bhattacharya.
Thank you, Dr. Anuradha. Next, I invite Dr. G.S. Bhattacharya to speak against the motion. Dr. Bhattacharya, please.
Thank you, ma'am. And before I get my slides into the share mode, let me say thank you to my good friend Ranga. Ranga, I always thought you were my friend. And that's one of the reasons I decided actually to take on this. I hope my slides are clear. Yeah, okay.
I must tell the audience one thing. GS stands for Genes and Science. He's full of science and genes, and that's the reason why here he's there to talk about the liquid biopsy. And wherever the genes and science is there, GS is there. I mean, that's in short about him. Thank you very much, GS. Despite many odds you've joined in, I really appreciate that.
Yeah, I mean, and before I start off, let me make a statement that debating against Dr. Chogle is always difficult. And this is the only time I'll say Dr. Chogle, because I'm going to keep saying Anuradha. We both work together on a lot of things, and I learned a lot from her in my method. So my stuff is very clear that Dr. Chogle did a very great job, Anuradha did a great job of doing a very balanced statement. There was no hype, there was no rhetorics, and that was fantastic. So based on picking up from where she started out, I would say that this is a promising tool of the new decade, but I'm going to try and bring out certain things that were wrong against this. To start with, today is World Sleep Day, so don't fall asleep while I'm talking. You can always sleep at night, and keep in mind. I'm going to tell you something when I start off now that, the problem with entire medicine has been that we have got to realize something. A bad laboratory test is worse than a bad drug. I am going to try and just put a line out here and say, we all do the trastuzumab giving tests of looking at HER2. But what does HER2 tell you? If you really follow HER2 and give trastuzumab, it's 1 in every 6 patients who is doing well. Give it a thought of its effectiveness. I'm not saying efficiency. Look at it, and then you see what it is. So based on this particular thing, we have another upset is that we in medicine today are looking for evidence within evidence-based medicine, and we forget the $1 billion subset analysis. This is a brilliant paper that came out saying that pemetrexed, a drug which we use in lung cancer, now in adenocarcinoma lung, whenever you don't have a proper target, is one particular drug actually has never been proven superior. This is from JAMA and JAMA last year. Similarly, let me just put it across. Anuradha has already brought it across that biopsy is a gold standard, but, and she's talked about the but, so I'm not going to get into it. JAMA Network carried in 2020 a series of 10 articles which they said were most quoted. And I want you to go down to JAMA Oncology and see there was a article called Genotype of Personal Metastatic Non-Small Cell Lung Cancer. This paper is today considered to be a hallmark paper in saying that liquid biopsy should be trying to get in where standard biopsy is. That's the paper, and that's the conclusion what was drawn out. But I would like you all to read the editorial. I also would like you all to pay attention to what I'll say. 29% of patients with therapeutically targeted mutation who had undergone NGS testing for both plasma and tissue, the mutation was detected only in tissue. That means if you stuck to only plasma, you wouldn't get it. That's one. Keep that in mind. So that's something which we saw last year. The second part is whenever we talk of the term liquid biopsy, we are never sure what we are saying. There are too many things within the same group. We have the cell-free nucleic acids. We have the exosomal nucleic acid. We have the circulating tumor cells. Do remember that CTC was something that we all talked about and we all know what's happening. So without getting into details, and just to put it across to you all, I would say that if someone tells me that liquid biopsy is not invasive, I would say it is invasive, moderately. Please go back and remember that the first surgical procedure that even today Hamilton Bailey in his procedure of surgery says is the commonest surgery ever done is a surgery that's done on the blood by drawing venesections. The point is like this, that you have to remember that there are some issues. And what are those issues? Those issues whenever you do a liquid biopsy is that we do a normal biopsy rather, it's highly invasive, costly, and static snapshot of the tumor. But when we look at liquid biopsy, we also remember that you're looking and trying to look for needle within a haystack. You have to be very careful. And it can be, as I said, moderately. Okay. Anyway, so let's have a look at it. The pros and cons of CTC, one of the types. It lacks validation and most qualifications technologies. It is expensive. There's a variation of what CTC means, and it's difficulty in reproducing it. And we need to have more than one method of doing it. Similarly, if I look at the ctDNA, I would see that different methods being followed all over the world. Quantification of whole exome sequencing are still developing fully. We are not yet very sure. Anuradha does a great job. She's trained for it, but most people don't. Technically challenging to look at the whole exome. It is not suitable for every patient or every type of cancer. And please remember, they are released from apoptotic and dying cells. And that is where the importance is. So one level of analytic, if I really look at it carefully and have a look, we would see that especially ctDNA circulating at any given time is low. Tumors of medium size do not produce enough ctDNA. It is even more difficult to extract ctDNA if I'm looking for it, and specifically in a woman who's pregnant or who is carrying it, or a person who has a graft somewhere in the body. This creates certain degree of problem. Lastly, and the most important, is the identity of the cancer which you have if analyte is present. So Anuradha talked about the recommendation and standardization of the methods, and I'm absolutely the same page with it. It has to be done and done properly. But a substantial effort to see how a ctDNA analysis is done, we still do not have enough data in spite of having guidelines. The reference mutation has to start with having to know the original mutation, and that has to come from the solid tumor by a solid biopsy. Second, the size profile of DNA in the material has got its importance. The matrix makes an important differences that we keep talking and seeing very often. So let's have a look. When a patient has got metastasis, we do get a lot of circulating DNA, but when it doesn't, it doesn't. Similarly, the sensitivity of the test varies in a similar way. The expected low ctDNA in pre-symptomatic or early stage of cancers is a challenge to use the tool as a diagnostic or a prognostic marker in early cancer. The second part is this, that clonal hematopoiesis of indeterminate origin can actually have a lot of mutations which can mimic cancers. We have been having this, we have been talking of this, but we don't seem to have incorporated the protocols. Therefore, additional methods of making ctDNA is required to make it more sensitive. Different assays have been developed by different companies and different academics. There are different workflows and different methodologies. Sensitivities of these ctDNAs are different for different cancers. And finally, a confirmatory biopsy will be required if we're looking at it for a second time. Now, one of the best known FDA ones that people keep talking about is Foundation 1, Garden 360, MSK, and Plasma Select 64. There is very low congruence between these tests when you put up a paired sample. And there is insufficient congruence of this actually leads into choosing wrong therapy or when you try to combine two different methodologies. So that's the congruence that we see of the published article in 2017 in JAMA. We would see that majority of the patients do not have a congruence. And when this happens, you have to understand what happens when you are practicing. This is new in JAMA Oncology again in 2020, that if you use PARP, which now has got a inhibitor and has got a liquid biopsy test for it, we now know something 35% of those are overreading a PARP positivity when it is not there. Now that again is not fair if you're looking at the net predictive values. That's a busy slide, but just to tell you, the slide just tells you, these are slides I'll send over to Dr. Ranga if anybody wants it, is this approach to liquid biopsy needs to be improved, and that's how to improve it. So for all practical purpose screening, you have CTCs, you have ctDNA. Can we use it of today? No, we cannot, because they're not sensitive enough. What is the monitoring? Yes, and this is where Anuradha was right. This is somewhere that we can use it very carefully because it does make sense. There are pragmatic drawbacks when we're talking of potential in early stages, because it's still a large way to do it. And what do we do with the data? We don't know. Potential values, yes, picking up mutations that come up, but please remember, it picks it up in about 40 to 50% where it actually may exist in 70%. So that's something, limitations you have to remember when you do that. Finally is, what is the value that we can talk about in terms of relapse? We don't know. Does liquid biopsy used NGS over the standard NGS ever show you a survival advantage? The answer is no, it still doesn't. So if it doesn't, then I will just show you. If you look at this photograph, and this is like you're doing a barcode that you do, can you really make out which of these are abnormal? The answer would be very often you can't, and you have to use a technological method for that to make it a single pixel. Those are the marked ones that tell you how they differ. That is the problem which you have to solve. So different cancers, different amounts of ctDNAs, different amounts of circulating tumor cells. The same methodology cannot be used and applied. Different stages, different amounts, different methods, that needs to be done separately. Similarly, we have got to remember initial ctDNA cannot be used possibly if you do not have the tissue diagnosis. With that, I will stop and say thank you. I have been jaded today, I know, but still thanks a lot for accepting what I did.
Thank you, Dr. Bhattacharya and Dr. Anuradha, for a very lively discussion and very important and contemporary topic on lung cancer. So do we have time for any expert comments from the participants? Hello, Parinit?
Yes, ma'am, you can give your comments.
I am Dr. Rangarao. Do you want to want to share your comments on this?
I think it's been always a dilemma to get the diagnosis because tissue is an issue in lung cancer. And then we are struggling to get adequate tissue because the pathologist would want a chunk of tissue for each and every IHC and each and every driver mutation, whereas a liquid biopsy would make it easy. I think what is stopping us from doing both is the cost. And once the cost comes down, maybe we will have both together. That may be the final answer. And then as I think JS also has very well said that sometimes though the mutations and everything is found out, they may not be the definitive and the certain answers, and the clinical experience putting them on something more different also is an answer. I mean, I hope in next few years, this whole problem will be solved. And one of the things which you have, not in this debate, but the previous lecture was, we have different platforms for testing of the PD-L1 for different molecules, which is mind-boggling and, sometimes humiliating. I mean, you can't just say, I'm using Atizo, so use a different platform. I'm using a Pembro, use a different platform. So I think that thing really is a very puzzling thing. And the debate between the solid and the liquid biopsy will continue hopefully for a short time. And then we should have both at a lower cost. That's the dream.
Thank you. I just want to make one comment, and that is for the pathologists, because the pathologists should understand that they are the custodians of these important tissues. So while we do IHCs, we should be very thoughtful how much we should do and what amount of tissue we have got so that we can preserve tissue for subsequent molecular studies. And that's very important for the subsequent diagnosis. So now then, thank you everybody. And I hand over to Dr. Anita Ramesh, who is the moderator for panel discussion.
Thank you.
Dr. Anita?
Yes, a very good evening. Nice to see all of you. Thank you so much for having me here. And I start sharing my screen. Can I have access to my screen, please?
Yes, ma'am, please share.
Okay. Just 1 minute. I'll just open the slides and keep. Yeah. So, who is going to invite my panelist?
Please, you yourself invite them.
Okay. 1 minute. Can you just forward the panelist? Yeah.
Dr. Paneet may help to identify panelists and get them.
Yes, Dr. Anita, do you sorry, Dr.
Yeah, I have all of them list with me. Can I call them? Dr. Jatin Sarin from Chandigarh, Dr. Sajal Kakkar from Chandigarh, Dr. Shaheen Anais from Dubai to join us, Dr. Sarjana Dutt from Delhi, Dr. Prashant Mehta from Delhi, Dr. P.S. Subramaniam from Mumbai. Are all my panelists here?
Yeah, I'm there. Good evening, Dr. Anita.
Yes. Yeah.
Nice. Good evening,
Dr. Ramesh.
Yes. Thank you so much. What happened to the... Okay. Once you finish, I'll share my screen. Okay, I'll share my screen now. Yeah. A very good evening. Okay, please feel free to stop me at any point of time and your question. Okay. Now today we are going to concentrate on lung cancer and sarcomas. So quick thought process from our panelists. We can start with Dr. Jatin itself. Dr. Jatin. Yeah, what would be, okay, given a case of a bronchogenic carcinoma, what would be your approach to diagnosis and what tissue you want in a newly diagnosed case?
Well, in a newly diagnosed case, any kind of tissue will be fine. Even a FNAC or a cytology from which I can make a cell block, that will be enough for me, because we're going to have a limited IHC markers, and then the tissue would be preferably for NGS to test multiple targets or multiple mutations, and also for IHC for PDL1. Tissue has always been an issue in lung cancer, as said by Dr. Rangarao before. So from any place, I mean, if you can have a tissue, you should
It can
send
be
for
anything.
the test upfront.
Yeah, it can be an endobronchial biopsy, burst, it can be washings, brushings.
Yeah.
So you're comfortable with everything. FNSC. Would you insist on a true cut biopsy? If a good, already you can see a good lesion accessible
Yeah,
in this chest,
definitely.
or you would like to go for a fluid?
No, see, yeah, I mean, the biopsy would be preferable, but in most of the cases, practically it happens that we end up getting the fluid only. And with the cell block technology and all, we are able to test most of the things.
Okay, thank you. Dr. Sajal Kakkar, a quick question to you. Yeah, like Dr. Jatin said, somehow he will get issue for you. So what do you tell your pathologist, or how do you go about it? Knowing fully well it's a metastatic non-small cell cancer. Do you do just histopathology IHC, or would you would you be keen in running an NGS at this point of time?
Good evening, ma'am. So once we have the fluid or the tissue, so definitely we need a working histological diagnosis. And then if it's an advanced metastatic cancer, so we definitely would require EGFR and then ALK1 rearrangement studies to be done first.
Yeah.
And maybe then I will, once the report comes, I will think about doing NGS or other panels.
Okay, so you would just restrict yourself to
Initially, yes.
ALK only. Okay. Yes, Dr. Shahina has joined. Dr. Shahina. Okay. Dr. Shahina, please feel if you, as soon as she joins, you can tell her to talk, give her opinions. Dr. Sanjana Datta. Okay. Now, do you agree with Dr. Sajal that you will do only EGFR ALK and keep NGS for a later, or how do you go about it? She's there. Hello, Dr. Sajjana.
Ma'am is there. Ma'am is there. Yes. Dr. Sajjana, please unmute yourself.
Yes, I am unmuted. Are you able to hear me now?
Yeah, please tell me.
Right. Yeah. So thank you, Dr. Ramesh. So I work in a central laboratory setting, and our testing is really quite restricted by what the referring clinician requires. And in most cases, yes, I would say that in general, we get asked for a shorter panel of EGFR, ALK, and ROS and PDL1 to begin with. So these four markers are definitely what we get asked for. However, from the perspective of a laboratorian, I would say that yes, it would make lots more sense if one goes ahead for an NGS, because you start from a point of knowing the complete genotype of what all other mutations are present, which may impact how a patient may respond once a patient is put on any sort of targeted treatment. So yes, it would make lots more sense to go ahead and perform NGS at the baseline testing itself.
Okay, thank you, Dr. Sanjana. So yes, we heard two thought processes about this. Yes, NGS is one of the rising technologies, and it is not so well accepted in many parts of India, and that's why we are here to discuss, because it depends upon what center you are working, whether you're working in a medical college where I am, where we don't think about an NGS at any point of time, but definitely when I come to my corporate practice, yet it forms a major crux of the investigations to be ordered. Yes, we heard about liquid biopsy. Circulating tumor DNA forms a important aspect, or an important once the biopsy is not possible, or if you are in a second line, third line. Yes, we also heard from our first panelist that you can use effusion and nicely use. And I think this technology may not be available at many places. The cell block technique, collecting the cell debris and subjecting them to an analysis. Now, quickly to Dr. Prashant from Delhi. Okay, in your practice, do you order all of them in a center where you are, or how do you go about it?
I have slightly, yeah, can you hear me, ma'am?
Yeah, lovely, I can hear you.
Yeah. So I have slightly different way of managing my patients. I basically have two categories of patients. Some patients who require, early treatment, and some patients who can wait. So what I tend to do is I have a good interventional radiologist at my center, and I'm able to obtain tissue for at least making 2 paraffin blocks. My first block goes for minimal IHC. Sometimes we require IHC, sometimes we do not based on the morphology, and very minimal IHC, and then IHC for PDL1 and IHC for ALK and ROS1. This is the first block, and we get very early results, maybe 2-3 days or so. And the second block goes for, this is for those who require early treatment. And the second block goes for EGFR on the IDELA platform. That also takes 2-3 days max. So I'm able to get all these results within 2-3 days, and I'm able to start treatment and define the therapeutic plan. The second set of patients who can wait, I'm able to do the IHCs plus a targeted sequencing, like very targeted and hotspots kind of NGS, and where I'm able to obtain some important mutations, especially the EGFR, MET, exon 14 splice, and also RET, BRAF, HER2/neu, all the newer ones. So for that set of patients who can wait, I'm able to do a broader plan. So I basically use NGS as just another test. I'm not very always NGS centric, but yes, it is another tool which I find useful in some patients. But I'm not very, categorical about what exactly I'm going to do for a particular patient. I customize my plan based on how I should go about.
Yes, okay, Prashant, I also agree with you. Visceral crisis, that's what you are targeting at. Once immediate treatment, yes, we go for a shorter panel, but sometimes we just straight away start with the chemo. We may not wait for 2 to 3 times.
It happens. I agree, ma'am. I agree.
And we can add the targeted drugs later on. Yes,
absolutely, ma'am.
With your thought process, we need to have a good tissue to divide up into 2 paraffin blocks and send it for 2.
Yeah, so since last 2 years, I'm able to do that. Maybe my interventional radiologist is becoming better in providing me as much tissue. Maybe initially, maybe 5 years back, this was not the case. I also used to face a lot of problems, but now it is getting better with passing time.
Yeah. Okay. A quick question to Dr. P.G. Subramaniam. Okay. Do you do all this which is recommended in NCCN guidelines, or you do like other speakers restricts to ALK, ROS, and EGFR, NTRK, the drug also I think is about to come but not yet available. Dr. Subramaniam, please. Name is there with us.
He was there, yes.
He was there. Okay. Then what should we do? We move back to Dr. Jatin. Okay. Do you do all these other mutations which are shown in the NCCN guidelines?
Well, when we send NGS, all these mutations are automatically done. But the thing is, most of the many patients are not able to have accessibility to the therapies.
Yes.
But at least we know that there were targetable mutation in a particular patient. And obviously they end up taking chemotherapy, but we know the prognosis beforehand, and we can offer them treatment, or if they can take it, otherwise yes, we send all these.
Yeah, I think you're right. Finance becomes logistics, becomes an issue. They just do the test and leave them alone. Then what happens? Fine. Yes, but
Dr. Ramesh, can I make a comment out here?
yeah, doctor. Yes, doctor. Yes, please. You're most welcome. Thank you.
Well, Dr. Sareen, I don't agree with you. If my patient cannot afford the treatment or doesn't have an access to the treatment, why waste the resource on doing a test?
Right, sir. The thing is, if we cannot afford, then even the sometimes, you know, then we again, as Dr. Prashant said, we choose the patient. Actually, we see.
So I mean, then Jatin, we need to put it very clearly as far our understanding is concerned. At the onset, when the patient walks into your room, stratify them.
Yeah, that's
if you stratify them, then it works out the way even I heard Prasant commenting on it.
Definitely,
fine.
If a patient is
I think the first is what the patient walks in, stratify the patient to decide what test is required, because at the end he's going to pay out of his pockets.
Yeah.
Yes, Dr. GS, one thing I want to tell you in addition, actually, I want to tell in the beginning, there are some situations we don't do the molecular testing. When I'm in the medical college, I will not, they don't have the money to do ALK and EGFR. Maybe I will do an EGFR because you have a generic. Okay, I might do an ALK now because I have a generic.
Yeah,
like 90 to 95% in the medical college, I will not send for molecular testing. When I come to corporate.
Perfect, and underline that.
Yes, because they don't have the affordability. We get from the government scheme 3,500 rupees. With that, we will able to get the chemo, and that's it. And with chemotherapy, again, the survival, a couple of difference a month, and they are happy. They are continuing. We don't do. Okay, let's move on to the next bit of the talk. Okay, now we know that these are the recommendations. We'll not go through into it. Let's look into soft tissue sarcoma. We have short of time. Dr. Sajal. How do you approach to a soft tissue sarcoma? Now it's a big umbrella, much bigger than that what a lung cancer is like. So how do you go about? Do you really, have you brought in all these PCR based methods, NGS methods in your daily regular practice?
Ma'am, I'm a radiation oncologist. So basically,
up to you.
Yeah, no, that's what I'm answering. But we have tumor board discussions.
Yes,
but
please.
Still in advanced and metastatic sarcomas, when we see, we are not routinely doing these NGS studies as much.
Okay. You're not doing. So Dr. Shahina has joined in a very, I would like to hear from her in her scenario, which is different from that in India, where people locally are all completely reimbursed. So these should not be a problem. Next is Sarjana, your views on soft tissue sarcoma. Quite a big basket. I'm also getting.
Yes, quite a big one. I mean, till recently, of course, one would by and large restrict to testing only for the Ewing sarcoma using the break apart fish probe. But of late, we are being asked for the specific translocation partners. So we specifically get asked that, okay, EWSR1 with one particular translocation partner or the other. And I would say that the FOXO, the PAX3, PAX7, and FOXO translocations, those again are something that we are being asked. Of course, not as much the other. Now, just a few queries have started coming in for the MYOD1 mutation analysis also, but the rest of the markers are really yet to pick in. So,
Yes.
So in terms of routine clinical testing, no, not as much.
Not you don't know, but then some of the tumors we know. Dr. Prashant, back to you. Well, like say fibrosarcoma protuberance, do you do the platelet derived growth factor, or like some of them like synovial sarcoma where there is an abnormality in the X genes? Okay, how do you go about some of the tumors?
Yeah, so yes, there is some role of doing a more comprehensive testing, especially with regard to some parameters like the tumor mutational burden. I have been able to find a high TMB in some sarcomas, And I have 2 patients right now in IO because they're TMB high, and one of them has responded. And this was a leiomyosarcoma, and this is a difficult tumor in the third, fourth line setting, very difficult to control. And this patient responded. So
third and fourth line, you're using NGS upfront.
Upfront, I have not done much NGS for sarcomas, but I've probably done in second line or third line, especially to look for TMB now, because this is kind of one of an approved biomarker now. So some patients who can afford it, because it has also become cheaper now, because doing a TMB used to cost much more. But I'm using the Indian generic versions of TMB, which is about 20-25K now. So it is quite affordable now. And also I have published my data on TMB. It's a multicentric data though, about 50 odd patients of TMB with a with the Indian generic TMB testing. It's about much cheaper than foundation one or something. So that we presented in WCLC 2 years back.
But then the patient should be able to afford the immunotherapy also. You had this and done
so
it.
for immunotherapy also, I'll tell you, we are working as a group. Maybe you have read some of our papers from Science and Cost Cancer Consortium. We have published on a few problems, and one of them is immunotherapy costs. And there are strategies with immunotherapy which can be used to reduce the cost of immunotherapy, like frequency of administration and the dosing. Like a 2 mg per kg dose instead of a 200 mg flat dose. All this, because Indians are lighter weight, and the pharmacokinetics, we can exploit the pharmacokinetics of IO to reduce the cost of IO. So I have many such patients on a lower dose of a longer frequency of Keytruda or low dose nivolumab. I have some patients, and it does work. It does work in an appropriately selected population. So, and it's the right strategy to use, because there is pharmacokinetic data, and the dosing is mostly for the Western population who are heavier, and there are pharmacokinetic differences. So we can exploit it for our population.
Prashant, I do agree with you. How do we do metronomic chemotherapy? Okay, data is more from India rather than other countries.
I absolutely agree with you, ma'am.
Sometimes 100 milligrams of nivolumab I have used 3 weekly, 4 weekly, depending upon the patient, and the patient continues. Yes, you're right, and that's one way of looking into it. Okay, now quickly a quick question to Dr. Subramaniam. Dr. Subramaniam has logged in.
Ma'am, Dr. Dawood has joined, ma'am.
Yeah, Dr. Shaina.
Hi, how are you?
Yes, a very good afternoon for you and an evening for us. Nice of you. And I think we are going to finish this session. Shahina, quick words. How in Dubai will you use NGS for all your patients of lung cancer and sarcoma? And that will be the concluding comment for this session, because we are done with the Indian scenario.
Oh my goodness. So that's a lot of pressure.
No, you tell me. Would like to hear from you.
So at least in my practice, actually any patient that has advanced metastatic disease is discussed in our multidisciplinary tumor board, and all patients with lung cancer, sarcoma patients, metastatic triple negative, metastatic hormone receptor positive, and colon cancer patients, as well as patients with unknown primary, automatically their tissue samples are sent for full molecular profiling. In the realm of lung cancer, if we don't have enough tissue, then we will incorporate liquid biopsies in these patients, but it is standard of care for us in the first line setting.
Yes, and Dr. Shaina, and so actually if they are an UAE citizen, they get everything free?
No, so UAE citizens have insurance, and the insurance does cover it. So long as you make a good case for it. But you have to realize that the UAE citizens only make up 10% of the population over here. So most patients are actually not UAE citizens, and the insurance actually covers for all patients.
Yes, you're correct. And that's the ideal way. But in India, well, that's what we discussed. We have different methods, like in a medical college, we will not do anything. And then some places we'll do restricted panel. Some places, depending on the patient, divide up into 2 blocks. Also, the drugs that we use, we change the doses, we change the timings. and just to meet so that we are able to deliver the treatment to the right time to the patients and using the latest of the technology. Shahina, it was nice hearing from you. Thanks, Dr. Jatin, Dr. Sajal, Dr. Sarjana, Dr. Prashant, and we didn't hear Dr. Subramaniam. And my big thanks to Dr. Angarao. It's always a pleasure when you pick up the phone and softly say, can you moderate? I cannot tell no. Thank you very much. Though I have 4 meetings, I have 4 talks today evening after this. I'll sign off now. Thank you very much, sir.
Yeah, thank you, Dr.
Thank you, Dr. Ramesh. Thank you, co-panelists.
The busiest and the most famous, lady oncologist across the other side of the India. I think every day there's some newspaper cutting or some news about you. Very proud to have known you and to be associated. Thank you very much for gracing the occasion. Thank you. And wonderful discussion.
So many people joined in. Thanks a lot. Thanks.
Over to Parneet, Dr. Parneet, for conducting of these sessions.
Dr. Parneet, please unmute yourself.
So thank you, chairpersons and the panelists and the speakers for such a wonderful session. Now I'll ask Dr. Mansi Chauhan, my co-hall coordinator, to introduce the chairpersons for the breast sessions. Thank you. Over to you, Dr. Mansi.
A very warm welcome to all of you again, our respected faculties, chairpersons, and delegates. It has been a really wonderful session on pathology beyond the IHC markers. Had a wonderful session. So without any further ado, I would like to invite our chairpersons for the next session on breast cancer. So our first chairperson is Dr. Kanchan Kaur. Welcome, ma'am. She's an associate director at Breast Services Department and Cancer Institute, Medanta Hospital, Gurugram. Welcome, ma'am. For the next chairperson, has Professor Chintamani joined yet?
We've not been able to contact him. We are trying. His number is switched off. So hopefully he'll join in some time.
Yeah, so I had a word with him. He's operating. He would join shortly. So okay. Professor Dr. Chintamani needs no introduction. He'll be joining soon with us. Our next chairperson, I would request Dr. Prashant Mehta. He's a medical oncologist at Asian Hospital, Faridabad. I would request him to chair the next session, please. So I would request the chairpersons now to please invite the speakers and the debaters and moderators of the panel discussion, and please take the questions during the session, and most importantly, your expert comment at the end of the session. So over to you, ma'am. Dr. Kanchan, are you there?
Yes, she's there. She's there. Dr. Kanchan, please unmute yourself, ma'am. She was just here.
So let me invite the first speaker for today, Dr. Chaityanan Kopikar. He needs no introduction. He's a head of department and a consultant oncoplastic surgeon, and my mentor, Dr. Kopikar, is the director of breast services at Jahangir Hospital, Pune, and he'll be starting with the next talk. Over to you, sir.
Good evening, everybody. Good evening, Mansi. Thank you for the invite, and I'm sorry I'm a bit rushed today because of my commitment to another forum right now. So I have to join that forum by 7:15. So I will try and get this talk done as soon as possible. So can you see that? Because I think my screen has gone off.
Yeah. So now you can start sharing. Thank you so much, sir, for taking out time. I know it was very difficult for you to squeeze in for us. So thank you for joining us. And now you can share your slides, sir.
So my slides have been shared already. Can you see my share?
No, sir, we can't, sir.
Okay, I'll share it again.
Yes, sir. Now it is visible, sir.
Yeah. So I was saying, so sorry for this rush thing, but unfortunately that commitment was given long back, so I could not cancel that. So thank you so much, and I bring greetings from Pune, from the Center for Translational Research and the International School of Oncoplastic Surgery. The probable truth is that biology is always the king, and whatever else you try to do, biology will always reign. And we know today that it's not only the disease burden that really, dictates surgery or the treatment, but also biology and the therapy. And therefore, this has been made use of by using neoadjuvant therapy to decrease tumor burden and increase the breast conservation rate and reduce axillary surgery. And it facilitates tumor shrinkage. It also reduces the tumor burden in the axilla and hence induces us surgeons to actually reduce the extent of ALND in our patients. Breast surgery after NACT, how can we reduce the mastectomy rates? Does oncoplastic surgery increase BCT rates? Are the two questions that I will address. As we all know, and I'm not going to go into the details of this because of the want of time, but NAST is well established with increasing PCR rates. Most systematic reviews have shown BCT equals mastectomy, but the conversion to mastectomy to BCT has only been fair, and that's about 40% in really good centers. And the EBCTCG overview of 2018 suggested an increased IBTR with BCT. It suggests this for many reasons, and it also lays out strategies to reduce IBTR. They say that careful tumor localization was probably not thought of in the papers that they had listed. Proper pathological assessment and rat path analysis was absent, and appropriate radiotherapy techniques were not elicited in those papers which they reviewed. And therefore, they suggested certain ways of countering that. We at our clinic have this paper that we have written out and has gone for peer review. And of 135 patients where we showed that with oncoplastic surgery and with a protocol, we could increase the breast conservation rate to around 76% in all surgeries where we did neoadjuvant chemotherapy. The approach was very simple. First of all, local staging was done very immaculately with USG, mammography, or MRI when needed, MRI in very few cases. Use of intraoperative ultrasound was essential. Clip the tumor after it shrinks was our policy. So we don't clip the tumor just when the patient has a true cut biopsy, but after it shrinks to about 1 centimeter in size is when we put in clips, and we put in Liga clips like this as seen here. We put it in with a needle, and we mark out the center of the tumor. Then we place wires for residual calcification, remove all suspicious clinical or radiological findings, intraoperative rat path analysis for definition of lesion and margins of resection, and we ensure margin negative status on frozen section, even if you have to wait for half an hour. If scattered tumor seen in the specimen, we excise further margins. So we mark the tumor bed with markers for radiation, and no ink on margin concept is not to be accepted in NACT. We try to achieve larger margins. Basically, once we have, so basically what is the tenet of all these, this study that we did? It was oncoplastic surgery, and we began with this therapeutic mammoplasty where we have done over 230 cases now, and which have a very good margin positivity rate of less than 2% and a local recurrence rate of only 1.2% at 2 years. The summary of post-operative complications you can see were minor, and most importantly, the prompts from our study, which we have presented here, satisfaction with breast, satisfying outcomes, psychosocial well-being, and sexual well-being have been extremely good with our patients. This paper also has gone for peer review. We have also used the LICAPs, ICAPs, or the perforator flaps in our surgery when we do oncoplastic surgery for the post-NACT patients, and this has really increased the extent of which surgery can be done. So we have presented this paper, Extreme Oncoplasty. There's a growing interest, and we presented 40 cases, and in that a lot of locally advanced breast cancer with limited response to chemotherapy were presented in that paper, and we again showed good results with satisfaction of breast. The prompts were excellent with that paper. NAST cohort of 135 patients, we found that the local recurrence rates were only 1%, metastasis. This was at 11 months. I have got other, more recent data later. LOBCs, LABCs that qualified were around 84, and they too, so I'm not going to go into the criteria again for the lack of time. Qualified for mastectomy, 84 out of them, conversion to mastectomy was 71%. And when PCR was high, we had a higher rate of breast conservation. Again, the breast Q parameters were excellent at 1 year. Prompts were very good in all these various aspects that we studied. The local recurrence rates at 2 years, you can see, are only 3% in all our patients who were treated with NACT and breast conservation surgery. One of the cases which we are showing a very good response after chemotherapy, excised the skin, took a flap on based on a medial pedicle and symmetrization on the other breast, and this is a result after 3 years, no local recurrence, and doing well after surgery. This is another patient, the microcalcification and the tumor excised widely, and basically reconstruction done. And this is her after 3 years of surgery. This is another patient, large tumor. We use the LICAP or the LTAP in this patient, which is a perforator flap surgery. And basically, we could get a good result, as well as this patient is doing well after 2 years. This is the huge LICAP that can be picked up. We use a lot of ultrasound for mapping out the tumor. That is the LTAP, and you can see it is raised on the LTAP vessel from the axilla after an axillary dissection. And this is completely inserted into the breast to reconstruct the breast. And you can see this is our post-op result. So with all these type of surgeries, one is able to, we have early encouraging results at 2 years towards safety of oncoplastic surgery. Meticulous techniques for ensuring margin negativity and oncologic safety should be followed, and patients should be converted to mastectomy if required. There is a changing era in axillary management. First, of course, it was all ALND. In era 2, from SLNB came, and if it was negative, no further treatment. In the era 3, even if SLNB is positive, if it is clinically node positive, axillary imaging post NAC. If it's a normal axilla, you do a sentinel node. If it's a negative SLNB, RT, SLNB. If it's positive, SLNB, ALND plus RT. Abnormal nodes, of course, will go for axillary dissection. Now, axillary management, you need to change it because NAC downstages axilla by 40%. This is a study from MD and from Sloan Kettering, where they showed that 41% of patients could avoid a ALND. The parameters which favored SLNB were high grade of tumor, HER2 positive, and TNBC. So therefore, the SLNB is now going up and up, and the axillary lymph node dissection is dropping as far as the international scenario is concerned. And this is the epochal papers that really started off the SLNB, which showed that local regional recurrence and overall survival is better at 15 years. De novo SLNB, NSCBP B32, and other papers also stated that maybe one node removal is not enough. Even in de novo SLNB, probably 2 to 3 nodes would be better for a good false negative rate of less than 10%. And in the locally advanced or the patient in the patient that need maybe an axillary clearance as of the olden days, FNAB core biopsy, and then if the the node is positive, neoadjuvant chemotherapy, and may convert them to SLNB. And these are the 3 papers that showed Ecosoxy Z71, Sentina, and the SNFNAC, where they had initially reported a high false negative rate. But when 3 nodes were dissected, they came down to 9.1, 7.3, and 4.9%. And therefore, the conclusion was that more nodes removed, less was the FNR and better overall survival. But again, there are new papers that have shown that overall survival doesn't really get affected by a false negative rate of being higher. Somehow the adjuvant therapy of radiation, chemotherapy, and hormone therapy take care of the residual nodes in the axilla. These are again further papers that showed that more than that false negative rate of SLB after NST drop when you remove more nodes. So the usual suggestion is that at least 3 or 4 nodes should be removed after NACT. Targeted axillary dissection, lot of procedures have been elucidated. Mari procedure, Cordell et al., Diego, and Barrio have shown that they have brought down the FNR to 4%. 5% if you use targeted, but does it really help? There are new studies from Germany, one, and Kahler et al., who also who have suggested that maybe you do not need a targeted radiation or a targeted axillary dissection. And in 220, Vyas et al., they said that 1 in 120 benefited with clipping. Now these are new papers, and I would suggest that all of us should read that to understand what they are trying to say. Therefore, the problems, but in identifying more SLNBs, these are two papers from Mamtani and Laws, inadequate identification of 14%, 33%, failed mapping of 3%, 16%, and less than 3 nodes traced in about 16 to 20% of patients. And therefore, there are problems of identifying SLNB after NACT. Then there is a new kid on the block, that is the ICG lymphatic mapping. Due to the lower molecular weight of ICGs, diffusion into disturbed lymphatics may be better. In a de novo situation, ICG is known to identify more sentinel nodes. So a combination of ICG and blue dye may be a good option in post-NACT SLNB. Assessing the effects of NACT on lymphatic pathways. This is a paper from Japan, which they showed that SLN is, the conclusion was that the SLNs were safely performed with ICG mapping. And also post-NACT, this study showed that SNB using dual method, including ICG, was comparable with the conventional RI method for breast cancer patients. And again, comparison of ICG and blue dye in Lancet Oncology shows that the ICG is significantly better than blue dye, and there are no significant statistical difference between ICG and radiocolloid. So it probably could, be replacing radiocolloid in institutions that have no access to radiocolloid or nuclear medicine departments. And this is a paper from Singapore, Mock et al., which he showed that he compared all the various methods of ICG of sentinel node biopsies, and ICG probably came up on the top with 97% dissection rate and a very low false negative rate. And this is our overall studies. Here we have 425 patients SLNB, 287. We have a false negative rate of 7.1% and post NACT of 10%. No NACT, that is de novo patients 271 with a FNR rate of 6%. And when we used ICG and blue dye, again we were able to achieve the same FNR rates in our about 134 patients. Overall, the number of nodes we dissected with ICG and SLNB were 3.83, as against blue dye alone was 2.86. This is not statistically significant, but tending to show that with ICG you pick up a little bit more. To conclusions, post-NACT SLNB is applied to selected patients only, cannot be applied to every patient. ALND is recommended whether micro or macro mets is in post-NACT patients. Clipping of a node at the time of diagnosis is probably recommended as of today, but is still questionable. A minimum of 3 to 4 nodes needs to be resected. Dual tracer is recommended. iSpy may be better. Our data with dual tracer and with iSpy is very, very encouraging. And thank you so much for this opportunity to speak to all of you. Thank you.
Thank you, sir, for the very detailed yet concise topic on surgical management of breast as well as axilla after NACT. We have lost Dr. Kanchan in between due to some technical glitch, but she's with us now. So, ma'am, can you hear me?
Yeah.
I'm handing it over to you now.
Good evening. Sincere apologies. I seem to have suffered some glitch. Dr. Kopikar, good evening as always. A very wonderful talk as always, and always inspiring us to push the boundaries as oncoplastic surgeons. Next, I would like to invite
Sorry, I'll have to leave the meeting. I have to go somewhere else. So
Sure.
Sorry for that, and thank you very much again.
No, thank you for the wonderful
Thank
talk.
you, sir. Thank you for joining us.
Thank you, sir. Thank you, Dr. Kopikar.
So I would like to invite next Dr. Rima Pathak, who is the Assistant Professor, Radiation Oncology at Tata Memorial Center, Homi Bhabha National Institute, going to talk about fast and fast forward. How fast can we go in Indian population? Looking forward to hearing this interesting talk. Dr. Rima?
Yeah, I'm just sharing. Just give me a moment. Are you able to see my screen?
Yes, ma'am. Please start a slide.
Yes, we are. You can start slideshow.
I'm not able to.
Ma'am, please start.
Okay, so good evening, everyone. I'll be presenting the buzzword currently in breast radiation oncology, that's the FAST and the fast forward study. So just in brief, here I just wanted to show that 50 grain 25 fraction is considered the conventional fractionation and the age-old standard fractionation that has been used in breast cancer for many decades. This was originally compared with the START B trial, that is the 40 grain 15 fraction, which was the moderate hypofractionation. And we already know the results of the UK START B study, which showed that it is slightly less toxic and equi-effective as the conventional 50 grain 25 fraction. While this was ongoing, they also compared a more hypofractionated or something called as ultra hypofractionated regimen, where they compared 28.5 grain 5 fraction once weekly with the 50 grain 25 fraction. And we will discuss about the study results of this study, which is also called as a UK FAST study. Both of these were randomized controlled trials. By the time the results of UK START B and the UK FAST studies were out, the initial results, they conceptualized the UK fast forward study. And this study looked at treating the patient in just 5 fractions in 1 week and 1 fraction daily at 26 or 27 grain 5 fractions. So in brief about these two studies, as you can see over here, the UK fast study compared 50 grain 25 fraction to 30 grain 5 fraction and 28.5 grain 5 fraction. Both assumed a different alpha by beta of the breast cancer and the breast. The UK fast forward study, which was started a bit later, compared it with the then conventional or the then standard, that is 40 grain 15 fraction with 27 grain 5 fraction or 26 grain 5 fraction over 1 week. Both of them assumed alpha by beta of 3, and that was known from the initial START results. The dose was different because one assumed no treatment time compensation. That means when you reduced from 5 weeks to 1 week, one arm assumed that that did not make any change in the overall treatment effects, whereas the other arm assumed that that would make an effect. The study in FAST, you can see that most of the patients that were included were older patients, invasive carcinoma, breast conservation only, node negative, margin negative, less than 3 centimeter, only ER/PR positive, no other histology allowed. Whereas fast forward was more inclusive. It had all patients older than 18 years. Patients could have any type of surgery, T1 to T3 tumors. Previously, they were taking only N0 to N1, but later on in the lymphatic arm, they have taken patients with N1 or N2 disease. Any type of receptor status was allowed. HER2 patients were allowed so long as they were willing to take trastuzumab. Later on, they had excluded patients who were older with better prognostic features because of the PRIME2 study. Now, one thing I wanted to also emphasize was that patients with more than 10 nodes, patients with supraclavicular nodes or IMN nodes were not included in the fast forward study. What were they measuring? FAST was basically an alpha by beta finding study for an ultra hypofractionated regimen, as you can see over here, whereas fast forward was a more pragmatic study looking at a 5-year local relapse rate. Looking at the planning perspective, I would focus on the fast forward because it's a more recent and a more modern trial. So as you can see, all patients had to have CT based planning. So none of them were conventionally planned. Planning was similar in most ways as we would do today. They had to mandatorily contour the ipsilateral lung and heart to know the doses that the lung and heart were receiving. For the lymphatic arm, which was later opened in the study, brachial plexus had to be contoured and doses to brachial plexus were noted. All patients were treated with bitangential RT or field-in-field IMRT and not inverse planning IMRT. Tissue heterogeneity correction had to be applied for all patients. What was different from most of our practice currently is that daily imaging was used. As you can infer, if we are treating in just 5 fractions, daily imaging will be necessary because if there are any setup errors, it would mean that nearly 20% of your treatment would be delivered erroneously. So daily imaging using EPID or KVMV volumetric imaging was necessary. All displacements were corrected at each fraction. Similar verification was used if a conformal photon boost was added later. Quality assurance was quite strict, and credentialing of contouring, treatment technique assessment, homogeneity, prescription point, and IMRT technique were assessed before each center was selected for participation. They also had rules for assessment of daily QC protocols, and QC was compulsory even for the image verification protocol. What happened in this study? As you can see, that I would like you to focus on these curves. The red one is the 40 gray in 15 fraction, which is the standard arm. The blue one is 26 gray in 5 fraction, and the green one is 27 gray in 5 fraction. As you can see, after the year 2, both the red and the blue curves continue to separate, and they don't meet any time later. So the estimated cumulative incidence of IBTR at 5 years was 2.1%, which was originally expected to be around 2%. And in the 27 gray arm, it was 1.7%, whereas in the 26 gray arm, it was 1.4%. And this was statistically significant for non-inferiority. The absolute differences between the IBTR compared to 40 gray was minus 0.7% for the 26 gray arm. Here you can see different survival outcomes. Here you can see that IBTR, locoregional relapse, distant relapse, any breast cancer related event, and all-cause mortality are all suggesting that it is a non-inferior regimen when compared to 26 gray in 5 fractions. Looking at the physician-reported normal tissue endpoints, and here you can see that these are similar between the standard arm and the 26 gray arm. The 27 gray arm continued to show toxicity or higher toxicity as compared to the 40 gray arm, whereas the 26 gray arm continued to be either more favorable or at least isotoxic as compared to the 40 gray in 15 fraction arm. And therefore, the study concluded that the 26 grain 5 fraction over 1 week is non-inferior to the standard 40 grain 15 fraction over 3 weeks in terms of local tumor control and in terms of normal tissue effects, at least up to 5 years, because they've shown here 5-year data. Now, just dialing back to the UK START-B study, and I'm just refreshing these results because I'm going to later on compare. So here I'm just showing you important findings. You can see over here that these curves also begin to separate by about 2 or 3 years. And these are comparing the conventional fractionation 50 gray in 25 fraction to the 40 gray. And this is from the 10-year updated result. And they don't ever meet later on. Similarly, here you can see that the disease-free survival also was statistically significantly better in terms of the 40 gray arm. And in terms of the normal tissue effects, you can see that the normal tissue effects were also mostly in favor of the 40 gray arm as compared to the 50 gray arm. Here you can see different endpoints, and again, it's the same thing that you saw in the fast forward study results presented. Most of these studies showed that the 40 grain 15 fraction or the modest hypofractionated arm was slightly better and in some ways statistically significant, whereas hence it was reported that it is iso-effective and isotoxic. Now comparing, so here I don't want you to see any numbers, any figures. I just want you to focus on the separation of these two graphs. Here I'm showing you 5-year results and then at 7 and 10-year results. On the left is the START-B study and on the right is the fast forward study. Here you can see very similar two curves of the ipsilateral breast tumor recurrence. And you can see that at 5 years also these two curves continue to separate in the fast forward study. And it is my gut feeling that it is going to continue this way. I don't think that later on at any point in time, the 26 gray arm IBTR rates are going to cross the 40 grain 15 fraction arm. This is a busy slide, but it is a very important slide. And what I would like to point out over here is that for patients, these are comparing patients with the START study, the fast forward, and the TMH data. And this is just to give you an Indian flavor and comparing it to the Western data. You can see that there are stark differences between our population and the studies that we have recently discussed. That you can see that the Western population or the UK data was more T1 heavy, whereas we are our Indian patients are more either T2 heavy or T3 patients. In terms of grade, this is also one of the more important and stark differences. Most of the patients were either grade intermediate or low grade in the UK studies, whereas nearly 83% of our patients are grade 3. In terms of the receptor status, as we all know, the Indian patients show slightly higher HER2 positivity as well as triple negativity, and that is seen over here as well. In terms of the conservation rates, you can see that the patients who underwent breast conserving surgery were much higher in the UK cohort, whereas nearly 50% of our patients still undergo mastectomy, and there is no doubt about it. Why do they undergo that? Because of the locally advanced nature of their disease. We see that a much higher number of patients have node positivity in Indian setting as compared to both the UK fast forward study as well as the UK start B study. In terms of boost, as you can see, most of their patients had lower grade disease as compared to our Indian population, and there is no wonder that only 50% of their patients were eligible and received boost, whereas nearly 95% of our patients received boost. Again, because of the disease extent, most of our patients undergo neoadjuvant chemotherapy, whereas barely few undergo neoadjuvant chemotherapy in the UK setting. Now, what does this difference entail? Does this mean that these results are not applicable? These differences were present even when the START B study was published. That means these could we not have taken START B results also seriously? Here you can see that similar studies and similar questions were raised for START B study as well, and several other studies were done later to prove that even in the high risk cohort, the moderate hypofractionated regimen, that is either 40 grain 15 fraction or 42.6 gray in 16 fraction, or the Wang study, the Chinese randomized controlled trial of 43.5 gray in 15 fraction, were comparable and clearly established safety and efficacy of hypofractionation in post-mastectomy patients as well. Now, looking at the TMH results, so not even looking at the Chinese result, what about the Indian patients? So we did a retrospective comparison of consecutive patients who were treated in 2013 and 2014, which was 15-25 versus 14-15, because we changed our practice in 2014. And here you can see for both BCT patients as well as for the MRM patients, which are on the right side, the MRM are the Indian MRM, Indian locally advanced breast cancer patients who are really T3 and really T4 rather than being early T3s, and grade 3 patients and high risk factor patients. And all of these patients continue to do well despite using the moderate hypofractionation. People then complain about the late side effects, saying that this is just 5-year data and we may not be able to extrapolate. But then none of the previous moderate hypofractionated studies showed excess toxicity in terms of cardiac toxicity or second cancer, no excess recurrences, no brachial plexopathies. And for a radiation oncologist who believes in the radiobiology, if you can understand this particular table, you will see that the alpha or beta, even if you assume to be of 1.5 gray for the neural tissue or for that matter for the heart, you can see that the both UK START study as well as the 26 grain 5 fraction arm of the fast forward study are both moderate, are both slightly underdosing rather than overdosing any of these structures, and hence these late toxicities are not expected to occur. What are the challenges? Looking at the Indian scenario, does it help us to adopt these this particular strategy of 5 fraction treatment? We have a large population, heterogeneous practices. We have poor access to specialized healthcare and oncological training in medical and paramedical fields. We have poor penetration of breast conservation rates even now. We have lack of RT services and additional expenses, lack of awareness in patients as well. So healthcare as such is a low priority, and it's reflected in our budget allocation also. So which is why we need to try and see how to improve access in the given current scenario. If we use ultra hypofractionated regimen, and red is only for the COVID period where we would reduce the infection rates and it will be both beneficial for the hospital and patient, but beyond COVID, it will mean reducing expenditure for stay and travel for the patient. Lower toxicity would mean lower expenditure for treatment of toxicities, improved access to RT without compromising outcomes, reduced treatment interruptions, and improved quality of life. For the hospital, it would mean increase in number of patients that can be treated in limited hours, reduced working hours of the machine and its running cost, improvement in quality of the treatment, lower rates of toxicity, and higher patient satisfaction. What has our TMH experience been in terms of treatment using the fast and fast forward regimen? I would just want you to focus on a few important aspects. We are currently able to do that is because of our current quality assurance program. We have daily QA on machines. We use monoisocentric techniques, so there is no match line issue for the supraclavicular field. We do cross audits of nearly 95% of the cases. And in a recently conducted retrospective study of 100 consecutive patients, we saw that none of our patients had a mean heart dose of more than 3 gray. Most of our patients with a field-based PTV showed more than 95% coverage. We already had started using the fast-based protocol-based treatment pre-pandemic for patients who had compelling reasons to not be able to take daily RT. And during the pandemic, we've successfully treated patients with both fast and fast forward protocol using simultaneous integrated boost wherever it was possible. In terms of acute toxicities, just 1 second. No excess skin or mucosal toxicities were seen. We saw that the toxicities with fast forward regimen peaked by about 2 to 3 weeks. So for people who want to start using this treatment technique need to be aware of this. There were no other untoward side effects seen. So in summary, ultra hypofractionated RT with the current planning techniques can routinely be used in most centers. Uniform treatment policies and standard planning and treatment techniques allowed the UK multi-center study to be established and to to function appropriately. Therefore, you need strict QA for generalizing these results in your particular center. During the pandemic, if you are faced with a challenge, whether the patient will receive RT versus not receive RT, I think you should rather use this particular option for this patient. Beyond the pandemic, I would suggest that the fast eligible patients can continue to receive fast directed treatment of fast protocol based treatment because 10-year results are already available. For the fast forward, you can conclude that looking at the start data that these patients will continue to behave as per the start regimen, and therefore early breast cancer, node negative patients not requiring NACT and those with favorable biology can be treated with fast forward. Thank you.
Thank you, Dr. Reema. That was a very educative talk. In want of time, I'll quickly invite Dr. Vivek Agarwala, who is a senior consultant, Department of Medical Oncology and Hemato-Oncology at Kolkata Narayana Super Speciality Hospital and Rabindranath Tagore International Institute of Cardiac Sciences. And his topic for deliberation today is recurrence cause in early breast cancer, tailoring therapy as per score. Dr. Vivek Agarwala, welcome.
Thanks a lot. Thank the organizers for giving me this opportunity. So I just have 10 minutes and I would go ahead with my talk. So talking about recurrence scores in early breast cancer, tailoring the treatment as per score. So the age-old EBC-TCG meta-analysis with more than 1 lakh patients and more than 100 trials told that the relative benefit of adjuvant chemotherapy is around 33% reduction in mortality, and this benefit is there irrespective of age, HER2 status, tumor grade, ER/PR positivity. However, this mortality reduction is actually depending upon the absolute risk. Patients with high risk have higher benefit, low risk with lower benefit, but this doesn't take into account the tumor expression or gene expression and the immunohistochemistry. So the predictive risk or the chemosensitivity is lacking. And the age-old Bonadonna study with more than 25 years follow-up also shows that there is a 25% of these patients without any adjuvant systemic therapy, even the node-negative patients were included, did not have relapse. So the current practice of personalized medicine seeks to identify this group of patients who would not benefit from adjuvant chemotherapy, and we can avoid the toxicity. Now, the bone of contention is the luminal A subgroup, where recommended treatment is endocrine therapy alone because they are not chemosensitive unless they are having a very high tumor burden. But how to identify the luminal A from the luminal B? We based on the clinicopathologic surrogates, and there is a almost 25 to 20% discordance when we are going by the clinicopathologic. So currently chemotherapy selection is based on these clinicopathologic factors as well as the patient's preference, toxicity, tolerance, including all these things. And they are often integrated into certain tools like the Predict Plus or the Adjuvant Online for better prediction. But what we need is better prognostic factors and predictive factors. And when we look at the different personalized treatment, we now have recurrence risk scores based on the gene expression, by which we can actually predict better what patients are going to benefit and prognostify these patients better. So if you look at the gene signatures, they are the first generation signatures, MammaPrint and Oncotype DX, where they have both level 1 evidence as well as the grade of recommendation as per ESMO. And then there are also certain second generation signatures like the Prosigna and the EndoPredict, which also have good level of evidence, but their evidence is still retrospective and the grade of recommendation is B. Now, talking about the recurrence scores, Oncotype DX is the most commonly and widely used recurrence score, which is by 21 genes, and it predicts the distant relapse risk within 10 years. They were clearly able to prognostify the patients into low risk, intermediate risk, and high risk based on this scoring. But the TaylorX study actually made it into how we can clinically utilize this. So the TaylorX study did not include node positive patients, and in these patients, the risk scoring was slightly modified, as the low risk scoring was 0 to 10 and not 0 to 18. So include only the low risk ones safely, whereas the high risk were more than 25, that is 26 to 100. And in the intermediate risk, that is 11 to 25, they randomized the patients to experimental arm of endocrine therapy alone versus chemo plus endocrine therapy. The high risk received chemo and the low risk received endocrine therapy alone. So looking at the results, what we see that the low risk arm had really good results with almost 94% in IDFS rate and 98% OS rate at 5 years. But most of these patients were clinically low risk. 93% were less than 3 centimeters, 98% were PR positive, and all these patients were very low risk in nature. Talking about the intermediate risk, so yes, there was a de-escalation, because what was shown is that with the addition of chemotherapy, there was no improvement in the endpoints. Both the chemo arm as well as the non-chemo arm had almost same IDFS, OS, relapse-free interval or the distant relapse-free interval. Also to note is that all the arms, the arm A, B, and C were almost doing equally, but despite giving chemotherapy, there was no improvement in the high risk arm, which really tells us that this score in the high risk category is only prognostic but not predictive of benefit of chemotherapy. So if you conclude the TaylorX results, recurrence score from 11 to 25, endocrine therapy was non-inferior to chemotherapy plus endocrine therapy. So no benefit of chemotherapy in the entire population. If you look at the recurrences 0 to 10, so endocrine therapy alone does very good. And in the high recurrence score, even giving chemotherapy, you are not improving much. They are having almost 14% event rates. And the most important observation was that there was some chemotherapy benefit in the intermediate risk group with the score of 15 to 25 in patients who were less than 50. So this subgroup analysis showed some benefit and it was likely related to chemotherapy induced ovarian ablation. The criticisms were it was a very selected population of low risk. There was no information on other risk factors that we clinically utilized, like the Ki67, LVI, histology, mitotic index, intensity of ER staining. There was also the design did not compare a strategy with genomics testing and without genomic testing, and there were frequent changes in the threshold. Now the AREX Ponder data that was presented last year included the node positive patients which had 1 to 3 node positive in the intermediate to low risk score, that is less than 25, randomizing them to chemotherapy plus endocrine therapy versus endocrine therapy alone. And here the primary objective was invasive disease-free survival, and they hypothesized that chemotherapy will increase the benefit. There will be increasing benefit with increasing recurrence score. But recurrence score was not able to benefit, show the relative benefit of chemotherapy. Also, the chemotherapy use and recurrence score were found to be independently prognostic for IDFS. And if you look at the IDFS of the entire population, there was no benefit in the entire population with chemotherapy. But there was an interaction with menopausal status. And the premenopausal status, there was a 5-year, 5.2% absolute difference in the IDFS, which was not there in the postmenopausal population. Similar in the overall survival, there was some 1 to 2% benefit. So what it concluded was that in 1 to 3 positive nodes in postmenopausal women with a recurrence score less than 25, they can safely remove adjuvant chemotherapy and go for only endocrine therapy, whereas those with positive nodes with recurrence score less than 25 in premenopausal women, they are likely to benefit significantly from chemotherapy. Also, we are now, there is a model of integrating this recurrence score with the clinical covariates of grade, size, and age to better able to predict a 10-year absolute benefit. And this is also available online. Now, coming to MAMA print, which is again a 70 gene analysis, next most commonly used. Again, only two differentiations: good signature versus poor signature. The good signature has very good outcomes with only 4% breast cancer related mortality, whereas the bad signature, there is 50% patients who are dying of breast cancer. And the MIND-ACT study, again, in the clinically low genomic low risk group, no chemotherapy. In the clinically high genomic high risk group, chemotherapy, whereas in the discordant group, they randomized patients to chemotherapy versus no chemotherapy. The primary endpoint was DMFS, and it met the endpoint because in the clinically high genomic low risk without any chemotherapy, it exceeded the 92% set with the 95% distance metastasis free survival. Also, we can see that in the discordant group, all the patients had excellent prognosis except the clinically high and the genomic high risk group. And in the clinically low genomic high risk group also, the benefit was only 3.6%, which was not very high. So the only group where this score was actually, it is important to do is the patients with clinically high and genomically low risk group, where it was clearly shown that there is no absolute difference between chemotherapy and no chemotherapy. And again, when you look at the patients by age, in patients who were less than 50 years, there was a 5% difference, but in the patients who are more than 50 years, in this subgroup, there was no difference. So the conclusion with MIND-ACT study was also that, with lymph node negative or lymph node positive patients, in patients who have a clinical high risk but a genomically low risk, in these patients, we can safely forego chemotherapy. So where to apply the genomic low risk genomic test? So
to the time,
just concluding. So in the ER positive, HER2 negative subgroup, these patients where there is no clear indication, there are few high risk and there are few low risk factors. These are the patients who are probably going to benefit from genomic low risk. And even in the MIND-ACT, just as we said, in patients who have clinically high risk, in those patients only we need to do the genomic test. In patients who have a clinically low risk, there probably we can safely forego chemotherapy. These are the guidelines which also show the same thing. There are other signatures like the Prosigna and the EndoPredict, but again, there is only retrospective evidence, so we'll not discuss them. Breast cancer index is something I wanted to just tell that this is the only factor which actually is predicting the late recurrences, because the oncotype DX only is predicting of early recurrence within 5 years. So breast cancer index clearly shows also that those who are having a high BCI probably going to benefit from an extended tamoxifen, whereas those who have low BCI are not going to benefit from an extended tamoxifen. Also, can assist breast is also something that is often asked. What I want to just say is that there is only retrospective evidence till now with it, with a natural selection bias, and it needs prospective validation, before universally we can use it. Although they say the patients are all Indian, it is more applicable to our data. And what we are also, I'm looking for is the Optima study, where they have looked at the genomically, genomic approach versus a non-genomic approach with Prosigna. So this is one thing that is going to tell us that whether with the genomic approach, are we going to have a better survival or an equal survival with lesser usage of chemotherapy. So this one is there. So my take home messages are that there are several genomic signatures, and these genomic signatures are mostly prognostic and not predictive. The identification of worse prognosis is not always equivalent to better response to chemotherapy. And what we need is probably an optimization of endocrine based therapy, which is a better option than chemotherapy in these patients. And the genomic test should always be used in combination with clinical and pathological factors and not in isolation. Thank you.
Thank you, Dr. Vivek. For the surgeons in the group, I'm sure this was a very lucid talk. Did put a lot of things in perspective. I'd like to ask the organizers whether we are going to go straight forward to the debate. And are the other chairpersons, are any of them on? I'm not sure.
Ma'am, you are.
We can start with the debate now.
So.
I don't think we have other chairpersons with us.
Okay.
We have Dr. Paras is there. Dr. Prashant Mehta is there.
I think he has left.
Okay. So Dr. Kanchan, you are the chairperson. Please continue, ma'am.
Yeah. So I think everybody loves a good debate, and definitely this is a very good topic for debate, especially for the surgeon in me when neoadjuvant chemotherapy is recommended to early breast cancers. So we have speaking for the topic, Dr. Tamajit Chaudhary, who is a consultant medical oncologist at Apollo Hospital, Kolkata. And I would like for him to start. Keep being mindful of the time, please, since we are already running late.
Thank you. Good evening to all of you. Requesting organizers to please share my slides.
So you can share your screen if you want, sir.
No, actually my laptop has some problem, so I'm just using my mobile. So please share it for myself.
Okay. Just a moment, sir. Just a moment.
Yeah.
Sir, please start.
Yeah, thank you. So thank you organizers for this opportunity. And for the next 8 minutes, I'll try my best to convince all of you that NACT in early breast cancer is not an option anymore. It's a mandate, at least if not for all patients, at least for some selected subgroup of patients and majority of the patients. So historically, NACT, the indication in breast cancer was to make inoperable cancers operable, means the patients who are not fit for MRM to make them fit for MRM. Now, the real question that time was whether there is any role of NACT in operable breast cancers, means patients who are fit for MRM. Next. Yeah, so in the quest of our search for the answer to this question, these following 3 randomized controlled trials, multicentric phase trials has been published in the form of NACBP B18, NACBP B27, and URTC 10902. We are all aware of the study. So in conclusion, what these 3 randomized controlled trials have showed or evidence that there is absolutely no difference between long-term overall survival and disease-free survival in NACT arm in comparison to adjuvant CT. But there is at least 10 to 15% increase in the breast conservation rate in the NACT arm. So breast conservation is the current standard of care in early breast cancer. We are all aware of that. And with NACT, there is about 10 to 26% of pathological CR. And the patients who achieve pathological CR, there is some form of survival benefit. Next. So there is an update of NACBP B18 and B27 published in JCO 2008. It has again highlighted the fact that although overall there is no difference in DFS and OS between NACT and adjuvant CT, but particularly in patients who are young, who are less than 50 years old, there is a trend of survival benefit favoring NACT. The HR for overall survival is 0.81 in that subgroup, younger patients. And moreover, both NACPP B18 and B27 have showed that patients who achieved a PathCR, there is a superior DFS and OS in comparison to adjuvant CT. Next, so there is additional one indication after the publication of these trials that even in patients for operable breast cancer, probably for conversion to BCS, we can offer them NACT. So, but we are not happy with these two indications. So we want further indications. So the next question is whether there is a role of NACT in operable breast cancers who are already fit for BCS. So if you dig the data further, NACPP B18 and B27 clearly showed that patients achieving PathCR, there is a long-term survival benefit. The DFS and OS, just look at the hazard ratio. The OS hazard ratio is 0.32 favoring NACT. Next. And any talk of NACT in early breast cancer will be inadequate without a presentation of this data. This is the famous EBCTG meta-analysis for early breast cancer of NACT versus adjuvant CT published in Lancet 2018. Again, highlighted the same fact. So patients who achieve PathCR, there is a survival benefit. So patients with high-grade tumors with HR positive TNBC, there is high chance of achievement of PCR. In long run, there is no difference between survival, no difference in distant recurrences, and there is at least 16% increase rate of breast conservation in the NACT arm. The only problem is at 15 years, there is 5% increased risk of local recurrence. Next. So the probable reason or probable explanation for this slight or minor increase in local recurrence in the NACT arm, the lot of search happened. And so probable reason is probably there is inadequate local therapy in the NACT arm. And that is evidence from the fact that the absolute increase in local recurrence was actually greatest in the 2 trials. So out of the 10 randomized control trials which were included in this ABCTG meta-analysis, 2 RCTs were there where surgery could be avoided completely in case of a clinical complete response after NACT. So the local recurrence rate in this particular 2 trials were 34%. And the same fact, if we dig further, that there was almost 1.5 decade earlier, there was another meta-analysis of NACT in early breast cancers versus adjuvant chemotherapy that also highlighted the same fact. So there is a trend towards increased local recurrence in NACT arm, but only for the subgroup of patients with inadequate local therapy. Patients with adequate optimal local therapy in the form of optimal surgery and optimum adjuvant radiation, there is absolutely no statistical difference between NACT and adjuvant CT in terms of local recurrence. Next. So whether NACT itself could be held accountable for the small increase in local recurrence rate is actually questionable. Next. Yeah, so there is a lot of confusion about whether there is an increased rate of surgical positive margin after NACT, particularly in BCS patients. But if we look carefully, till now what data we have, it's very conflicting and confusing. So the conclusion will be data is unclear to say anything about this due to insufficiently published good quality evidence. Next. Now that is a very important topic, that whether sentinel lymph node biopsy, which is the standard of care for axillary management in early breast cancer, whether SLNB is safe after NACT. So as per the data available from large multicentric randomized control trials in the form of Sentina and ACOSOC Z10 trial, it is clearly known that for a CN0, means clinical radiologically negative axilla patients, it's absolutely safe pre or post NACT. For CN1 patients who are converted to CN0 after NACT, the only problem, the false negative rate of sentinel lymph node biopsy post NACT, the range is slightly higher. Overall, the range is 8 to 14%. But at the same time, just look in the next line that it can be reduced to 5 to 7% by just removing 3 nodes or using dual tracer technique. So we have a lot of patient level analysis data supporting the NACT, particularly from CT NeoBC pooled analysis from German neoadjuvant studies, which have clearly shown that achieving PCR is associated with improved DFS and OS in the long run. PCR rate is high, particularly in high grade tumors, HR positive TNBC tumors, and PCR recommendation it is recommended as a primary endpoint for NACT trials and to be used for approval of newer agents in the treatment of breast cancer. That is FDA approval. Next. Yeah, so that this is again another meta-analysis which is published in JAMA 2016 that highlighted the fact of positive correlation between PCR patients in HER2-positive early breast cancer. So with NACT and anti-HER2 agents, the patients who achieved a PathCR in early HER2-positive breast cancer, they will have the survival benefit in comparison to patients who did not achieve a PathCR. Look at the HR ratio or hazard ratio, it's 0.34. That means patients with PathCR, they have at least 3 times higher survival than in comparison to the patients without PathCR. And this is again the largest in IPD meta-analysis, which is available till date in assessing the prognostic value of PCR with NACT, that is published by Laura Spring in San Antonio 2018, again highlighted the same facts that patients with PCR, they have a correlation with improved survival and improved DFS across all breast cancer subtypes. And just look at the second line, that overall the study findings support the concept of therapeutic escalation or de-escalation strategies in early breast cancer. Next. So the therapeutic escalation, the concept of therapeutic escalation as per the response to NACT in early breast cancer is highlighted by this phase 3 randomized control trial, the very well-known Catherine data. So all medical oncologists know this data very well, that particularly for HER2 positive early breast cancer patients with NACT and anti-HER2 agents who did not achieve a PAT-CR, probably adjuvant trastuzumab is not sufficient. We need adjuvant TDM1, which has really shown the survival benefit. And with this help of this data, this TDM1 got FDA approval also on 3rd of May 2019 for this very particular indication. Next. So I'll just end my presentation with this slide. This is ESMO Early Breast Cancer 2019. This is from Dr. Fatima Cardosa. So this clearly showed that except for less than 2 centimeter HR positive tumors, for all other subgroups of early breast cancer, for TNBC, for HR negative HER2 positive patients. So ESMO category 1A indication is start with systemic induction therapy and followed by, as per response, tailor your plan. So if Dr. Fatima Cardosa is saying something, it's not an option anymore, it's a mandate. Next. So these are my conclusions. The benefit of NACT in early breast cancer is actually multifold. It facilitates the BCS by downstaging of the tumor. The ultimate goal of NACT is to aim PCR, because we know that PCR, there is a positive correlation with survival benefit. Giving NACT will help understanding the tumor response to therapy and hence further tailoring of the subsequent management as shown in the Catherine study, and early eradication of micrometastasis, although till now there is no robust evidence, but we know that there is an improved distant recurrence rate, particularly in good responders with NACT. That's all. Thank you.
Thank you very much. That was very well put. You laid your case well. Next, I would like to invite to speak against NACT in early breast cancer for the rebuttal, Dr. Rajan Sahu from Panchkula. Again, I request you to please meet the time.
Okay, thank you, ma'am. So I'm trying to share my screen. So is it visible? On the slide is visible, ma'am?
Yes, yes, sir. Please start a slideshow.
Okay. Good evening, and my friend Dr. Tamojit has
make them a slideshow, sir.
Okay, fine.
Okay, sir.
Dr. Tamojit has tried his best to defend the role of NACT in early CA breast, but to my opinion, it is a wastage of resources and uncalled for. Why? I will discuss in the next slides. According to TNM staging, we know that breast cancer has been divided into early breast cancer, locally advanced, and metastatic breast cancer. When we talk of early breast cancer, it includes stage 1 and 2. So basically up to T3 and 0 disease, we are talking about early breast cancer. The NCCN recommendations are not category 1 for the use of neoadjuvant chemotherapy in early CA breast. It is only a soft indication that it may be considered in tumors more than or equal to T2 or in the node positive disease. So it's not a category 1 recommendation as of now in the NCCN for use of NACT in early breast cancer. So what are we going to debate today? That we know that NACT has an established role in LABC, that is locally advanced breast cancer. So that we are not debating today. As per NCCN recommendations, it is not a treatment to be offered to T1 disease or N0 disease. So the little bit category left is stage 2A and 2B subcategories, which we are talking about. That is T2 or larger lesions or the node positive disease. So these are this is all we are going to debate today. And even in these patients, if we look at this previous slide, that the recommendations are only for the HER2 positive disease and the TNBC disease only. So it is not the treatment for the hormone positive disease. And even in this small category, there are some candidates who are not where NACT is not applicable, like the tumors where there is extensive institute disease, where it is not possible to evaluate the invasive component of the disease, tumors which are impalpable, or where the margins are ill-defined and it is not possible to palpate the tumor and to assess the response of the chemotherapy. And though the NSCT has there are some theoretical benefits which have been explained about the NSCT, that it leads to better PCR and better survival, but it is also arguable, as achieving a good PCR does not always lead to a good improvement in survival. And another logic has been given about the more breast conservation surgery and less mastectomy rates. It is also not true 100%, and the treatment of micrometastasis. So I will counter all these points in the coming slides. These have not been proven in the randomized studies, and practically we do not find these benefits in early CA breast, and evidence is basically contrary to this. So what is the present evidence available? The randomized trials have not shown significant improvement in long-term outcomes with use of chemotherapy, and the results are similar whether we give chemotherapy before surgery or after surgery. The long-term results of these NSBP B18 and B27 trials, they have come up, and there is a 16 years follow-up for the B18 trial and 8 years follow-up for the B27 patients. And in the last part of the graphs, we can see that the survival is same in the B18 trial as well as in B27 trial, whether the chemotherapy is used upfront or in the adjuvant setting. So subjecting the patient to pre-op chemotherapy doesn't help in achieving the ultimate goal for the cancer treatment, that is the overall survival. And also there were some interesting findings in this review article. There were higher ipsilateral breast tumor recurrences in the NSCT group in the NSABP B18 trial, and also the use of NSCT led to delayed surgery and delayed use of hormone therapy, especially in hormone receptor positive patients, and its use was detrimental in these patients. There was another meta-analysis by Maury et al., which compared the adjuvant chemotherapy with the neoadjuvant chemotherapy in breast cancer. It also pointed out that more loco-regional recurrences were there in the NSCT group, to the tune of about 22% increased risk of ipsilateral breast recurrence in these patients. And they concluded that overall survival is not influenced by the timing of the chemotherapy, that is before or after, but it is more to do with the chemosensitivity of the primary tumor. And they did not confirm that the neoadjuvant chemotherapy led to better clinical outcomes as compared to the adjuvant chemotherapy. When we look at this forest plot, we can see that the overall survival and the disease-free survival, they were equivalent in the two groups, but there were more loco-regional recurrences in when we see the neoadjuvant chemotherapy part. So it disfavored the NSCT group, the loco-regional recurrences. When we see the practical usage of neoadjuvant chemotherapy, there was this study from the US to study the impact of neoadjuvant chemotherapy on breast conservation surgery, because one major logic has been given that it improves the breast conservation rates when we use NSCT. Many patients, even with larger tumors, they did not receive NSCT when this study pointed out. The reasons cited were patient preference or the comorbidities, which made surgery first as the better option in these patients. In the right side of the slide, the graph is showing that in the tumors which were less than 3 centimeter, use of NSCT was associated with more mastectomies as compared to and less BCS rates. The reasons were multiple, like the multifocal tumor or multicentric tumor, and especially the patients who were at higher risk of recurrence, that is the TNBC patients or the HER2 positive patients, they chose mastectomy as compared to the breast conservation surgery, even when NSCT was given. So this refutes the fact that NSCT leads to more breast conservation surgeries, as my friend was trying to prove. Even with the usage of the newer agents like monoclonal antibodies, when we look at the Neosphere trial and Affinity trials where the same agents were used in the neoadjuvant and adjuvant settings, the pertuzumab was added to chemotherapy and trastuzumab combination in the neoadjuvant setting in Neosphere trial, though it led to improvement in PCR. But when the same drugs were used in the adjuvant setting, there was no improvement in survival. So logically speaking, the drug which is showing effect in the neoadjuvant setting, it should show the effect in adjuvant setting also. But so the simply improvement in PCR doesn't lead to improvement in overall outcomes. Even the randomized trials on use of the targeted therapies showed the dramatic improvement in PCR rates, like we see in the when we use bevacizumab. The upper two bars, they show the usage of the drug in the neoadjuvant setting, and the lower two bars are showing the results in the adjuvant setting. So it led to improvement in the PCR, but there was no change in the overall survival, whether we see the bevacizumab use or the lapatinib in the HER2 positive patients, or the use of pertuzumab when added to trastuzumab and chemotherapy combination. So there was no correlation of the PCR with the overall survival. So the improvement in PCR has been given the a logical thing which we achieve with the NSCT, but a pooled analysis by Cortazar et al. It studied the about 12,000 patients in different trials, and they concluded that though the use of multiple drugs in neoadjuvant setting improved PCR, that is, usage of multiple drugs, adding more and more drugs in the neoadjuvant setting, it did not translate into better survival, and hence PCR cannot serve as a surrogate marker of overall survival. In this diagram, we can see that though the PCR is improving from 1 onwards, but the overall survival is not much different. Another logic of NSCT is to see the response and to change the drug during the course of treatment. But in the GPAR trial, the patients were initially given docetaxel, doxorubicin, and cyclophosphamide initially 2 cycles. And those who didn't respond to this chemotherapy, they were separated into 2 groups. One group received the same chemotherapy for 4 more cycles, and another group received vinorelbine and capecitabine 4 more cycles. And it was seen that the non-responders, the PCR rate was poor whether we change the drugs or not. So change in regime do not change the PCR rate in non-responders, suggesting that it is the innate chemosensitivity of the tumor that matters, and not the use of drugs upfront before surgery, and or the change in chemotherapy during the course of the treatment. The recent trial which has been cited by my friend, that Catherine trial, even in this trial which used TDM1 in the adjuvant setting in the patients who didn't respond to the chemotherapy and trastuzumab combination in the neoadjuvant setting, there was a heterogeneous patient population. It included patients from T1 to T4 and N0 to N3. So these findings cannot be generalized to the early breast cancer patients. And no study till date has shown that the PCR improvement, they lead to improvement in overall survival. And it is better to give the best chemotherapy in the adjuvant setting only when the tumor burden is less or almost nil. The tumor has been removed by surgery. So it is.
Dr. Sahu, we seem to have lost you.
Dr. Sahu?
Dr. Sahu? Is somebody going to contact him to check?
I'm just calling.
He's going to come on?
Yeah, I'm just calling.
He's still showing in the participant list, but we can't hear him.
Yeah, I think his camera's frozen. Should we give it another few seconds and then?
Maybe this is his last slide. He's not reachable on phone also. So chairpersons can Dr. Tamuji, do you have anything to say? Any rebuttal for Dr. Sahu till he comes back?
Yeah, so I don't have any separate rebuttal slides, but what I just want to share with all of you is that Dr. Sahu has tried his best to convince all of you that there is no benefit of achieving PCR. There is no positive correlation of PCR or PAT-CR along with long-term survival. But that is what data he has shown is only just a pooled analysis and few single trials, few separate trials. But there is a strong evidence from at least 2 large meta-analysis, one IPD meta-analysis in the form of EBCTG meta-analysis, which has been published in Lancet, and the second one is the LoRa string meta-analysis, which has been published and presented in San Antonio 2018, along with a lot of pooled data and updated data that clearly shown that, yeah, there is a correlation with all subgroups of achieving PCR, and that is, the correlation is much higher in patients with a subgroup of breast cancer where there is a high chance of achieving a PCR, just like HER2 positive and in triple negative subgroup of breast cancer. And I want to conclude with the single slide which I have shown as the last one, the Fatima Cardosa data, which is a early breast cancer ESMO 2019 guidelines, that except for less than 2 centimeter tumors which are HR positive, for all other subgroup of tumors, it is ESMO category 1A recommendation now to start with induction chemotherapy. So for all HER2 positive, all TNBC, except less than 2 centimeter HR positive. So all, for majority of the early breast cancer, it is ESMO category 1A recommendation. I believe that the NCCN also, it is an option, but it is not NCCN category 1, but in the coming years, it will be NCCN category 1, depending on the volume of data we are having nowadays. Thank you.
Thank you, Dr. Tamujit. I think Dr. Sahu is with us. So do you want to summarize the talk? Dr. Sahu?
Yes. Am I audible?
Yeah.
Yes, sir, you are.
Even considering the PCR rate of about 20%, so 80% patients are living with the tumor during the whole period of neoadjuvant chemotherapy. And we have to think of the patients who are not responding to neoadjuvant chemotherapy. They may progress on the chemotherapy, and many patients who were initially candidated for BCS, they may have to undergo mastectomy. And especially considering the axillary dissection, the patients who undergo neoadjuvant chemotherapy, if we plan sentinel lymph node biopsy upfront, then patient has to undergo surgery twice, once for the sentinel node biopsy and then definitely surgery. And if we consider sentinel lymph node biopsy after chemotherapy, it gives a poor yield and may lead to false negative results. My friend agrees to these points. So there is a psychological impact in the patients who do not respond to chemotherapy, or even till the time they achieve the PCR, they are carrying the chemo-resistant cells in their breast. So for small early breast cancer, I would say that it is not a treatment to be offered to the patients, and they should stick to the only locally advanced breast cancer patients. Thank you.
Thank you, Dr. Sahu. Dr. Kanchan, closing remarks.
Yeah, so I think both the for and against views have been very nicely presented by both the speakers. Being a surgeon who would like to wield the knife first in early breast cancer, I think even we are getting more and more convinced that patients, especially those who present with more aggressive breast cancers like the triple negatives and the HER2 new positives, would benefit in the long run by receiving neoadjuvant chemotherapy. But a big word of caution here, that patients who are chosen for neoadjuvant chemotherapy, the early breast cancer patients, the decision has to be multidisciplinary. The patient's wishes have to be taken into account. They have to understand what they're getting into. They have to understand that this may not always convert a mastectomy into a breast conservation. They must be examined at every 2 cycles to ensure that they are responding. And definitely there is no generalization. There is enough data on both sides of the coin. So I think a robust MDT discussion is the way forward. But as we can see it, we are probably moving more and more towards neoadjuvant chemotherapy with the CreateX data and the TDM1 showing a benefit of more chemotherapy in patients who do not achieve PCR. Although I would love to keep going on, I think in want of time, I'd like to thank the organizers for having me on and for such a wonderful, invigorating session. Thank you.
Thank you, Dr. Kanchan. Thank you, all the speakers and debaters. Had a very wonderful session, and definitely we addressed few problems for the next decade. Without any further ado, let's move on to the next session. Handing it over to you, Dr. Parneet.
Thank you, Dr. Mansi. Thank you. Very absorbing debate on early breast cancer. And I think patient choice is the only answer to solve this problem. So coming to the next session, the topic of the next session is cancer does not take a day off. So why should a CDK4/6 inhibitors? So for this, for the first talk, I would like to invite Dr. Rangarao sir. He's the he's the chairman Paras Cancer Group, Paras Hospitals, and he's the main organizing chairman of the conference as well. Sir has received many honorable awards, both Indian and international. So a lot of publications in the national and international journals, and has helped set up a lot of cancer centers in Delhi. I would like to invite you, Dr. Rangarao sir, for your talk. The topic of the talk is not all metastatic breast cancer patients are seen. Then why the same treatment for everyone? Over to you, Dr. Rangarao sir.
Thank you, Dr. Parneet. You've been very kind in introducing. And then I'm highly delighted to be on this panel, though it's become a little late, but I am sure we will have very, very exciting discussions to look forward to. So right in the beginning, I would like to welcome Dr. Shahina Dawood, who's come all the way on virtually from Dubai. And thank you for accepting this particular invitation. And all the other panelists who are kind enough to attend this. Coming to the metastatic breast cancer, over the years, we all have seen, as you all have seen, that this particular disease has so heterogeneous, especially the hormone positive. We have seen on one hand, very, very mild, very indolent disease where people have lived for years with few bony metastases without any harm to their bones or to their life. And then on the other hand, we have seen patients who have been having very aggressive disease, very, very aggressive disease, and then going on from one treatment to another, living for a shorter time than the other counterparts. And then in between, we have a different spectrum. So we are very clear and we understand very well that the metastatic breast cancer is completely a heterogeneous disease with a wide spectrum of the prognosis. Coming to the treatment over the years, what has happened is earlier we were all pushing in the chemotherapy in these patients. And then without understanding probably at that time when we had ERPR and HER2, all that understanding maybe about 3 decades ago, when the things dawned on us that, okay, ERPR is different from HER2 positive. And then later on, we understood the triple negative and so on. And then we understood that the hormone positive patients need not be pumped in the chemotherapy. They could be simply given hormonal treatment. We realized it. And then we stopped practicing the chemotherapy in these patients, except those few so-called with the visceral crisis. And then came in a new generation of drugs, that is the CDK4/6 inhibitors, which have changed the whole spectrum. But still, the question remains, we are still giving the similar or recommending a similar treatment to all kinds of breast cancers, probably with some exceptions. So maybe we'll have to think as to how to go about the treatment algorithms, develop them. So now I think I invite Dr. Shahina Dawood to have the first case discussions along with the other panelists. I mean, I will first let her talk, and then after that we have Dr. Amit Ratan, who is the moderator, and then Dr. Ashish Kaushal from Ahmedabad, Dr. Sandeep Goyal from Mumbai. These are the people, and they all of them may be ready. So first I will invite Dr. Shahina Dawood to come over the dais, and then invite. May I have the slide for the introduction for Dr. Shahina, please?
We welcome from Paras Cancer Conclave, welcome Dr. Shahina Dawood. Greetings from India, ma'am. Dr. Shahina is currently heading the medical oncology department at Dubai Medical College, United Arab Emirates. And over to you, ma'am, for the wonderful session, ma'am.
Yeah, and then we have listened to her many talks, and then they have been absolutely educative, very fascinating, very good ones, and we look forward to another deliberation from Dr. Shahina. Over to you, Dr. Shahina.
Thank you very much, and thank you for the kind introduction, as well as the invitation to come and share my experience with the use of a CDK4/6 inhibitor, specifically with abemaciclib in patients with hormone receptor positive metastatic breast cancer. And the first talk will be focused on endocrine resistant hormone receptor positive HER2 negative metastatic breast cancers. These are the disclosures, and these are specifically my disclosures. So the first case is of a 34-year-old lady. She's premenopausal. In September 2016, she was diagnosed with left breast cancer. It was ERPR positive, HER2 negative, node positive. She received adjuvant chemotherapy as well as adjuvant radiation therapy and was commenced, rightly so, on Zoladex as well as tamoxifen. By January 2019, she presented with rising tumor markers, and a PET-CT revealed extensive liver metastatic lesions. So I think some of the issues to think about in this case is, does this patient have endocrine resistant or endocrine sensitive disease? Should we be giving her chemotherapy versus combination endocrine therapy? And if you decide to give her combination endocrine therapy, is there a survival advantage associated with the use of first-line CDK4/6 inhibitor? Now, as you know, when you're seeing your patients in the clinic with metastatic breast cancer, hormone receptor positive, HER2 negative, they either have stage 4 de novo disease, meaning they have no prior exposure to any form of endocrine therapy, so they're essentially endocrine naive. However, the majority of your patients will have recurrent disease, and if they relapse very early on in the first couple of years while getting adjuvant endocrine therapy, they have primary resistance. If they relapse later on, it's secondary resistance, and of course, post completion of endocrine therapy, they have endocrine sensitive disease. Now, in this particular case, she had a very short disease-free survival, so I would classify her as having primary endocrine resistant disease. And as you can see on this slide here, using a CDK4/6 inhibitor in a cohort of patients with endocrine resistant disease is associated with an improvement in progression-free survival. You see that from the Paloma, Monarch, and Mona Lisa trials, where the Kaplan-Meier curves are separating very nicely, favoring the group of patients who are receiving a combination of CDK4/6 inhibitor plus fulvestrant compared to fulvestrant alone. And if you specifically focus on the Monarch 2 trial, you can see, irrespective of whether patients have liver metastases, PR negative disease, or high-grade disease, and these are typically factors associated with poor prognosis, you can see the hazard ratios are very similar in terms of PFS, and you can look at that median PFS very similar across the 3 cohorts at about 8 months in terms of improvement in progression-free survival. We also know that within the endocrine-resistant cohort, using a CDK4/6 inhibitor is associated with a survival advantage as well in terms of overall survival. And we get that data from Paloma 3, where using palbociclib plus fulvestrant results in a 6.9-month improvement in overall survival. This was clinically meaningful, but not statistically significant. Monarch 2 and Mona Lisa showed significant, in terms of statistics, improvement in overall survival. And you can see specifically in the Monarch 2 trial, there was a 9.4-month improvement in overall survival, translating into a 25% reduction in the risk of death from disease. And when you take a closer look at that Monarch 2 trial in terms of the overall survival, you can see that 26% of the cohort actually had primary resistance, very similar to the case that I've just presented. And what strikes you right off the bat is that you can see that the Kaplan-Meier curves are separating very early on in these patients who are supposed to have actually the worst prognosis. And you can see a 7.2-month improvement in that overall survival. In the rest of the cohort who had secondary resistance, you can see that the Kaplan-Meier curves are similar in the first couple of years, and then it separates later on, translating into an 8.1-month improvement in the overall survival of these patients. So coming back to the first case, this patient was given a combination of abemaciclib, Zoladex, because she was premenopausal, letrozole, and denosumab, and she achieved a complete response by April 2020, and she is still on treatment and doing very, very well. Now, just to look at the toxicity differences between these agents, you can see that neutropenia is similar or is an effect that we see with all 3 CDK4/6 inhibitors, but a higher incidence with palbo and ribo. AST, ALT elevation is more with ribociclib. Diarrhea is something that's associated more with abemaciclib. QTc prolongation, something that is specifically associated with ribociclib, and PEs, we do tend to see it more with ribociclib and abemaciclib. The second case is a lady who was 60 years old, postmenopausal. In 2018, she presented with a breast cancer that was ER/PR positive, HER2 negative. At baseline, she was found to have lung and bone metastases, and she was commenced on letrozole and Zometa at that time. And you can see that she did well until April of 2020 when we did a PET CT scan, and she had extensive liver metastases, extensive bone metastases, and that PET scan is actually pretty terrible, making you think that it wouldn't take her long to tip into visceral crisis. In fact, her liver function test showed that the enzymes were more than 1.5 times the upper limit of normal, but technically she's not in visceral crisis. We discussed her case in our multidisciplinary tumor board, and the questions we asked ourselves is, should we be giving her chemo or endocrine monotherapy or combination endocrine therapy in this particular case, especially since she had that terrible looking PET CT scan. At this point, we did a liver biopsy, and we sent that liver biopsy for molecular profiling. It turned out that she had a PIK3CA mutation, high genomic loss of heterozygosity, and a HER2 mutation, interestingly enough. As you know, in patients who progress on endocrine therapy, they have an 8% probability of developing a HER2 mutation, which could give them access to drugs like neratinib. So the question that comes up is, how are we going to integrate other emerging therapies in these endocrine resistant patients who've got hormone receptor positive, HER2 negative metastatic breast cancer? Well, we do have alpelisib for PIK3CA mutated breast cancer patients, as this patient has a PIK3CA mutation, and this data comes from the SOLAR-1 trial that randomized patients to either receiving fulvestrant or fulvestrant plus alpelisib in those patients with PIK3CA mutated endocrine resistant metastatic breast cancer. You can see there's an improvement in progression-free survival with the use of alpelisib plus fulvestrant. We saw the recent publication of the data that was presented at ESMO looking at overall survival. Again, there is an improvement in overall survival, but not statistically significant, but in my mind, clinically meaningful at 7.9 months improvement. And specifically in those patients with visceral metastases, you can see a very good improvement. But the problem with the SOLAR-1 trial was majority of patients had not received prior CDK4/6 inhibitors. So we saw the results of the BYLieve study at ASCO this year. In 2020, and all patients had received prior CDK4/6 inhibitors and had gone on to receive alpelisib plus endocrine therapy. And you can see in terms of median progression-free survival, 7.3 months, and the primary endpoint at which more than 50% of patients had to be alive at 6 months. You can see 50.4% of patients were alive at 6 months. Again, very similar data to what we're seeing in SOLAR-1. So again, you can use it post CDK4/6 inhibitor. So in this particular case, what would you use? And this is a question that a lot of people ask me when someone's got a PIK3CA mutation positive disease and has not received prior CDK4/6 inhibitor, what is it that you're going to use? Well, let's just look at a cross-trial comparison. In terms of overall response, higher overall responses with CDK4/6. In terms of duration of follow-up, CDK4/6 definitely has longer duration of follow-ups. In terms of progression-free survival, you can see with CDK4/6, it's 17 months versus the 7.3 months that you see with alpelisib after using prior CDK4/6, or 11 months in the SOLAR-1 if you have not received prior CDK4/6. And in terms of overall survival advantage, although we saw a clinically meaningful overall survival advantage with alpelisib, it was not statistically significant, while it is statistically significant in patients who have received CDK4/6 inhibitors in those trials. So my preference has always been to use CDK4/6 followed by alpelisib. And that's exactly what we did here. We gave the patient abemaciclib plus fulvestrant, and you can see from the PET CT scans here between April and July, the patient had a beautiful response in terms of her response to treatment with abemaciclib plus fulvestrant. So in terms of the algorithm for patients with an endocrine resistant disease, what does the future hold? Well, if the patient does not have visceral crisis, although in my mind, visceral crisis, the definition has certainly changed over time. If your patient has received prior CDK4/6, please test for the PIK3CA status. And if they're mutant, please give alpelisib plus endocrine therapy. And if they're wild type, endocrine therapy if it is still an option. But if they've not used prior CDK4/6 and they've got a secondary resistance, in my mind, CDK4/6 should be your first option. If they've got primary endocrine resistance, it depends on how heavily pretreated they are. If they are not heavily pretreated, then I would favor CDK4/6 plus endocrine therapy. But if they are heavily pretreated, and although I didn't show you the data for this from the PALOMA-3 trial, it doesn't really make that much of a difference if you add CDK4/6, and you really need to look at that burden of disease. Thank you very much.
Thank you, Dr. Shahinaz Daud, ma'am, for the wonderful presentation. Now we'll have a question and answer session with the experts. The moderator for this session is Dr. Amit Rotan. He's the HOD and consultant medical oncology at Manipal Hospitals, Bangalore. He has a lot of papers in national and international conferences and is also a member of European Society of Medical Oncology. The speaker, he's the moderator, and the others are Dr. Rangarao sir will be in this session, followed by Dr. Ashish Kaushal sir. He's a consultant medical oncology, HCG Cancer Center, Ahmedabad, and Dr. Sandeep Goyale. He is also a consultant medical oncologist at Kokilaben Dhirubhai Ambani Hospital and Research Institute, Mumbai. Thank you. Over to you, Dr. Rotan, Dr. Amit Rotan, sir.
Yeah. Thank you. Thank you very much. Good evening, everyone. I thank the organizers and Lily for having me here. So Dr. Shahina always gives us very, very interesting cases and a lot to deliberate about. So let's just start off the discussion. Though her talks are so lucid and clear that eventually when the last slide, you'll get a clear answer what to do. But eventually, when we see patients in clinical practice, we again end up deliberating what are the ways to move forward. So I think what I'll do is I'll quickly start off with Dr. Shahina's second case and put up a few points for our discussion. Dr. Ashish, if you're there, so you saw Dr. Shahina's second case with that extensive liver metastasis. That was a very scary PET scan. How, and the LFT was moderately high. How do you characterize your patients as those with visceral crisis? And how comfortable are you using hormonal therapy with CDK4/6, or would you have jumped to chemotherapy for that group of patients? Dr. Ashish, are you there?
Yes. Dr. Ashish is there. Yes, sir, he's there.
Dr. Ashish, you're mute.
Sir. Dr. Ashish, please unmute yourself, sir.
We can't hear you, Dr. Ashish.
Dr. Ashish, we can't hear you, sir. Please unmute yourself, sir.
I think there's a problem. Till Dr. Ashish sorts it out, Dr. Sandeep, I would put this across to you. The same question of the liver metastasis extensively.
So thanks, Amit, for the question. Now, whenever the patient has got liver metastasis, I'm always a bit wary of using hormone therapy with CDK4 inhibitor. The reason for that is, we all say that we should use chemotherapy only in visceral crisis. But my main question is, how many patients who go into visceral crisis are actually eligible to receive chemotherapy? Because they are not well. And the chemotherapy is quite toxic in them. We normally reduce the dose, so it's not very helpful. So these are the patients who have got liver metastasis, who are not in visceral crisis. I prefer giving chemotherapy upfront and then managing them, maintaining them with hormone therapy and CDK4/6 inhibitors. That's what I normally do, because I know chemotherapy I can give for 4 to 6 cycles. After that, I have to use hormone therapy. So these are the patients. So I'm a bit wary of using hormone therapy and CDK4 inhibitors upfront, because I feel that my main duty is to prevent them from reaching visceral crisis, and that's why I use chemotherapy. If the patient has got a solitary liver metastasis or 1 or 2 here and there, then that's a different thing. But extensive liver metastasis like this, I would go for chemotherapy.
Right. Yeah, that's definitely a perspective. When we see the burden of disease, we kind of get scared a little bit sometimes. Dr. Rangarao, sir, in this kind of a case, what are your thoughts, sir?
I think we must go through the times that we've gone through. Earlier, we were just putting them in the chemotherapy, definitely. That may be about 5 years ago, 4 years ago. And then ever since the CDK4/6 inhibitors have come in, I have preferred the hormonal treatment, the combination therapy, rather than the chemotherapy. Because the tolerance is far better and then the response rates are good. Actually, unlike what we thought that the chemotherapy induces very good and faster response and then the patients get better, the contrary is true to my mind after having used extensively these combinations of late. So I think I would prefer the combination rather than the chemotherapy in this patient. And then even in the visceral crisis, so-called visceral crisis, when the patients are actually getting sick, I'm not very happy to use the chemotherapy either. hormonal therapy today I would still be using in most of the patients.
Right.
Young patients, when shorter treatment-free interval, very apparently resistant, probably those are the only candidates where I would push the chemo, otherwise not.
Right, sir. Yeah. So our traditional treatment has definitely changed over time, and I think the definition of visceral crisis also, as Dr. Shahina mentioned, is clearly evolving. We are getting more and more comfortable using the combination CDK4/6 with hormonal in many more patients nowadays, and that's because of the high response rates which we are seeing. Right. Dr. Ashish, if you're there now, how do you choose between your CDK4/6 inhibitors in this group of patients who have this high visceral burden, and what are the thoughts in your mind? Which patients would benefit from which group of drugs?
I think I'm audible now. Am I audible now?
You're very faint. Very faint.
Very faint, sir. Very faint, sir. Can't hear you, sir.
Okay. I may leak out in through my.
Not audible, sir.
Okay, give me a time so I can leak on through my mobile.
Right. Okay, not a problem. Dr. Shahina, how are you using prognostic factors for choosing among the CDK4/6 inhibitors when you have taken a decision to use the combination?
So I don't use prognostic factors. I think that all the CDK4/6 inhibitors in terms of efficacy are equal in my mind. I don't think one trumps the other, but in terms of toxicity profile, I think they are very, very different, and that's something that we'll be discussing in the next presentation. So if my patient is an elderly patient who has a lot of comorbid conditions, especially cardiac comorbidities, I prefer to use either Palbo or abemaciclib. I stay away from ribociclib in those patients, just simply because I don't want to raise that QTc interval incidence. If a patient has, baseline benign neutropenia, I tend to use Abema more rather than Palbo and Ribo, because obviously we don't want them to be getting zero neutrophil counts in that sort of a situation. So I think it's an individualized thing. In terms of efficacy, in my mind, I think all three are the same. I think Abema has a lot of convenience attached to it in terms of it being a continuous dosing. And so compliance is a lot better. Rather than having the 3 week on, 1 week off schedule, but it really depends on the patient that's sitting in front of you. And I have to say, when I'm sitting in the clinic, it just depends on my mood of the day, what it is that I want to use.
Right. Okay. So toxicity is the major factor you're using for guiding you through the treatment. Dr. Sandeep, to you, I would want to ask, does that overall survival data kind of push you towards one side or the other? Sometimes it happens. No, we say there's an OS data there which you don't have with others. Do you think that sometimes it makes you choose?
Sorry, can you repeat the question? It's not clear very well.
I was saying, does the overall survival data make you choose sometimes? So when we look at this primary resistant population, we have some OS data with abemaciclib. So sometimes does that matter in your practice when you're choosing CDK4/6 inhibitors?
Yes, it does. Because there is some data with overall survival benefit, although I don't think it was statistically significant. But there is some data similar, rather than different. Yeah, they are similar.
Right.
Yeah. And hello. Yeah. So I feel all of that extent. And again, as pointed out, the convenience in the dosing, I think that is a big plus point for abemaciclib as compared to the other two molecules.
Right. So having a continuous dosing without bothering too much about counts. Yes. Dr. Ashish, I think you're there now.
Yeah, I think my voice is now, you can audible, right?
Yes, you're audible.
Yeah. So I just want to make a comment here. As Sandeep rightly mentioned, all CDK4/6 is more have the similar efficacy, but there is a certain important issue regarding the setup where they show their efficacy, especially in abemaciclib. You could see the patient who's having the primary resistance and the patient having a very poor biology, especially the patient had a lot of liver metastasis. And this subset, they still showed a very good efficacy. So I think, and like the similar case Dr. Shahina has mentioned, I think this patient having a very short disease-free interval and with heavy tumor burden, I think my preference would go to the abemaciclib. And another advantage with this drug, even in a mild to moderate hepatic dysfunction, we can easily give the CDK4/6 inhibitor. So I think that's another reason. And of course, there are other advantage, as Sandeep mentioned, continuous dosing. That's another little bit scores other than the CDK4 the combination.
Right, right. Okay. Dr. Rangaraj sir, do you, what are your thoughts on your single agent activity of abemaciclib, which you've seen? That's the only one which has shown that. Does that impress you for any reason? Do you think that will be useful for us anytime or not?
Yeah, so when we consider all the three ones and then have to choose, 3-4 things come into play. One is, of course, the single agent activity that is very effective and used as a single agent. That's one. Second thing is it has been responsible for some better overall survival. Number 3 is because of the continuous dosing. I mean, one doesn't forget. I mean, the heading of this topic was, I mean, the cancer cells don't rest, and then why should the treatment rest? And then here the toxicity profile is somewhat different. And having used the other two molecules, something like a 3-weekly chemotherapy, we need to monitor the counts in the patients. So here that problem doesn't happen. I think that's another reason why I would choose the abemaciclib over the other two agents. I think that's why I would use this particular agent. Yeah.
Right, right. Okay. All right. I think what we can do is the remaining questions, we can have a quick discussion after the next case of Dr. Shahina. So I will over to you, Dr. Shahina.
All right. I'm just going to share my screen. Can you see my screen?
Yes, ma'am.
All right. So going over to the endocrine sensitive patients, this is the first case. This is a 36-year-old lady. She's premenopausal. In November 2019, she presents with a right breast mass and palpable axillary lymph nodes, ERPR positive, HER2 negative. At baseline, she has bone, liver, and lung metastases. You can very clearly see the lung metastases on the MRI on your screen over here. And at baseline, her liver function is 1.5 times the upper limit of normal. So I'm not going to make this easy for you guys. The issues to think about here, again, is it chemotherapy versus combination endocrine therapy? Which endocrine therapy partner? And is there a survival advantage? We considered her not to be in visceral crisis, but you can see her liver is fully studded with disease. She does have stage 4 de novo breast cancer, so she has endocrine naive disease where you would expect the response rates to be very high. These are the results of the Monarch 3 trial. This was a phase 3 trial that took patients with endocrine sensitive metastatic hormone receptor positive metastatic breast cancer, randomized to receive either BEMA plus an aromatase inhibitor or an aromatase inhibitor alone. The primary endpoint was progression-free survival, and this was a truly endocrine sensitive cohort. Now, when you see the baseline characteristics, you can see in this setting, 41% of patients did have de novo metastatic disease similar to my patient. About 50% of patients had visceral metastases. You can see 25% of patients had prior AI therapy, and 54% of patients had no prior endocrine therapy. And you can see in terms of the treatment-free interval, about 62% of patients had more than 36 months treatment-free interval allocated in their designation. Now, when you're looking at the progression-free survival and you're looking at that response, you can see that in terms of median progression-free survival, the combination of abemaciclib plus an AI resulted in a statistically significant improvement in progression-free survival, 28 months versus 14 months, with a p-value that was very, very significant. And you can see in terms of responses, again, clinical benefit rate about 78% in the intent to treat population when you're giving abemaciclib plus an AI. Now, in terms of progression-free survival, it's not only the Monarch trial, it is also Paloma 2 and Melissa 2. And you can see that in the endocrine sensitive cohort, you can see that there is an improvement in progression-free survival across the 3 trials. You can see specifically in the Monarch trial, again, those patients with bad prognostic features, such as shorter treatment-free intervals, less than 36 months, those patients with liver metastases, high-grade disease, progesterone receptor negative disease, and high-grade disease, all of them benefit from the combination of abemaciclib plus an AI. Now, we did talk about response to CDK4/6 inhibitors. Well, this is, I think, a very nice extrapolation. Monarch actually looked post hoc at the response rates, and you can see that patients who had received abemaciclib plus an AI and they had liver metastases, the response rates improved from 20% to almost 57%, so very high response rate. When you give single agent chemotherapy, and this is an extrapolation from the CLGB 40502 trial, the response rate is 38%. So I would say combination endocrine therapy gives you either similar or higher response rates. So please do not be scared to give combination endocrine therapy if your patient is not in visceral crisis but has extensive liver metastases. Do not fear those PET CT scans. So coming back to this patient, we considered her not to be in visceral crisis. We decided to give her combination endocrine therapy because there is a survival advantage associated with it. You can see from these two trials, the MONALEESA 7 and the MONALEESA 3, both used ribociclib, randomizing patients in that endocrine sensitive cohort to either endocrine therapy alone or endocrine therapy plus CDK4/6 inhibitor. And you can see across the two trials, 30% reduction in the risk of death from disease. So there is an overall survival advantage. Now, one of the questions that comes up repeatedly is that should we be using only ribociclib, because MONALEESA 7 and MONALEESA 3 had used ribociclib, while we haven't really seen an overall survival advantage in the endocrine sensitive cohort for either palbo or abemaciclib. Well, my counter argument for that is, number one, the registration trial for MONALEESA has also as yet not shown an overall survival advantage, because when you look at the types of patients that have been enrolled in the MONALEESA 7 and MONALEESA 3, they are very different from PALOMA 2, MONARCH 3, and the registration trial for MONALEESA. One, in MONALEESA 7, it's a high-risk young cohort of patients who are all premenopausal. You can see the median age was 43 years, and the younger age is associated with more aggressive biology. In MONALEESA 3, they used a different endocrine therapy partner in terms of fulvestrant. Whether that made a difference, we simply do not know. But overall survival was actually specified in the whole cohort. And we know in MONALEESA 3, they included both first and second line. It was an exploratory endpoint to look at that first line cohort of patients. Nonetheless, like I said, coming back to my patient, we consider her not to be in visceral crisis. We commenced her on abemaciclib, Zoladex, letrozole, and denosumab. And just looking at some of those treatment emergent adverse events in these patients, you can see that, like I mentioned earlier on, the use of abemaciclib is associated with a higher incidence of diarrhea, almost 82%, but only 9% of these patients will have grade 3, grade 4 diarrhea. So it's actually not that bad. Usually the diarrhea, the median time to onset is about day 6 to day 8 post starting the abemaciclib. And if you're going to do dose reductions for diarrhea, it occurs at a median time of 28 to 41 days. I have to say, in my cohort of patients here in Dubai, diarrhea has not been so much of an issue because most patients are already constipated. So they're actually quite welcome with a nice soft stool every day. How do you manage that diarrhea? Well, you have to do education for your patients. If they see that they're starting to get loose stools, they should start with increased oral fluids and loperamide. That should take care of it 90% of the time. If it's a grade 1 diarrhea, you do not need to dose reduce. If it's a grade 2, let it resolve, re-challenge with the same dose. But if it's recurrent, then you dose reduce. If it's a grade 3, grade 4 diarrhea, you need to stop, let it resolve, and then you have to dose reduce. Now, again, a summary of the toxicities. As I mentioned earlier on, there are differences in toxicities. Overall, palbo and ribo present with a predominant bone marrow toxicity, while abema is predominantly GI toxicity, less pronounced hematological toxicity. But what you see on the slide is you have to see the type of patient that's in front of you. Are they elderly? Do they have cardiovascular disease? Do they have hepatic impairment? Do they have comorbidities? Based on that, you will choose the type of CDK4/6 inhibitor that you're going to use. Now, in this patient, she had a mild diarrhea that did not need any intervention. You can see that as soon as we started the abema plus endocrine therapy, her tumor markers immediately began to reduce. You can see this was her December 2019 scan, full of metastases. March 2020, she'd had a very nice, good partial response. So again, this is my last slide. What do I do in patients with endocrine sensitive disease? They all start with CDK4/6 inhibitor plus an AI if they're not in visceral crisis. But again, I think the definition of visceral crisis is going to evolve. And then once they progress, we test for that PIK3CA mutation. And if they are positive, they will get alpelisib plus endocrine therapy. If they're negative, they get endocrine therapy alone. And as you know, we have so many other targets beyond PIK3CA, including HER2 and BRCA, which we should consider in our patients post-progression on alpelisib and CDK4/6 inhibitor. Thank you very much.
Thank you, Dr. Shahina. Very, very clear and interesting presentation. Again, you brought up the toxicity is very, very important. That's something that we have to understand, and that's what we will have to utilize for choosing better our patients. Another good point Dr. Shahina has brought out is when we compare cross trials, we should be very careful because the inclusion criteria of patients were very different. And that sometimes when we compare them, we should be very careful in mentioning they're not exactly the same group of patients in all the trials. I think we have just the last 5 minutes, so I would quickly want individual experiences from our faculty. How has, because we have abemaciclib from the last some time now, and all of us have gained experiences. So let me start off, Dr. Sandeep, from you. What is your individual experience? Please talk to me about efficacy and also about your toxicity and the management you have done for it. Dr. Sandeep.
So with regards to abemaciclib, I think, as I mentioned earlier, the most important point which I feel is convenience of dosing. I don't have to repeat the blood test on a regular basis. Secondly, a practical point is when I use palbociclib, it's a 21-day on, 7-day off, and most of the times, while the patient comes to me with the reports, it's about 10 days or so, and the treatment gets delayed a bit. So with abemaciclib, this delay is avoided. So that's one factor. Secondly, just wanted to point out my personal experience. I've used in a patient with leptomeningeal disease as well. It was claimed that there is some penetration in the blood-brain barrier. So one of my patients who was not able to tolerate chemotherapy, because hormone receptor positive, I put them on letrozole and abemaciclib, and luckily with God's grace, she's doing quite well, on this treatment, along with intrathecal methotrexate. So there may be some element of blood-brain barrier penetration as well, which is thought to be from preclinical studies with abemaciclib. So I think these are the points. And with regards to, again, visceral crisis, I don't think so we can give chemotherapy in those because patients you've already lost by then. It's mostly, but the endocrine sensitive patient, like the second case, I would definitely go with the hormone therapy and CDK4/6 inhibitors. With the endocrine resistant, I'm a bit hesitant to use.
Right. Okay. Dr. Ashish, your personal experience with abemaciclib, both in terms of efficacy, toxicity.
Yeah, I think I would agree with Sandeep. This point to add here, I will be also the part of Monarch E program where I'm using Bima in a adjuvant setting. So I have a lot of patients who was treated in the last 2 years. And I think we have seen the toxicity profile, especially in Indian scenario. I think the diarrhea, which is the mention, is one of the major toxicity. And fortunately, the Indian patients are tolerated very well this regimen. And I have not come across where any patient in clinic where you have to stop this drug because of the toxicity, especially diarrhea is concerned. So I think the tolerance is good. And of course, the convenience of the drug, it's a continuous dosing, that would be definitely a prefer over the other CDK4/6 inhibitor.
Right, right. I would like to kind of say that even our experience has been, it's very limited, but we are definitely gaining experience. I kind of always said in initial patients, we really didn't see any diarrhea. So I was getting confidence saying, no, our patients don't have diarrhea. But recently we've had a patient with so bad diarrhea that we had to cut down the dose. So now we have seen the diarrhea also. So I think we will see toxicities as we treat more and more patients, but definitely we will be more confident managing it. So I don't think it's been really a problem. I'm very happy to hear about Sandeep's case because recently, this last month, I have started one patient with leptomeningeal metastasis with hormonal therapy, with abemaciclib, but without the intrathecal. So I want to see what happens. She's doing well as of now, but I would be very happy to know what happens. Probably in a meeting down the line next month, we could discuss this to see what our experiences have been with this. I think with this, I want to hear Dr. Rangarao sir's experience, because he has the maximum, he has a lot of experience in this. And with this, he can also give us the closing statement for this meeting. Thank you very much.
So I think I won't compare all the three things because we have the next panel discussing about which CDK4/6 to be choosing, and we look forward to that interesting panel. So I'll only sum up by saying that abemaciclib I have started using for the last 4 or 5 months. And then I must say that, yes, it has been very good. And the diarrhea that we were scared of after seeing the literature, what I've realized is that Indian gut is very different from all other guts. And then, so probably we have more high fiber diet. We have a lot of lactobacillus containing diet in the form of curd, especially in the south end, most of the places. So I think that's the reason why the side effects of diarrhea are much less. It's a well-tolerated drug. And then I think the diarrhea has not been really troubling as I thought. And then it's much easier to manage the other toxicities. That's been the experience. So coming to the closing statement, I think, you have any other question, Amit? In the panel?
No, sir. No, sir.
Right. So I think very little time left, and I'll just close up by saying that the choice of the three the CDK4/6 inhibitors has given much options to choose from. Cost is just one of them, but important thing is which patient. I just want to recall that Dr. Shahina said a cardiac patient would not like to give the thing for the ribociclib, and that's how we will choose a patient who's got extensive bony metastasis, cytopenias, and all that. We would not like to give them the CDK4/6 of ribo or the palbo, and we may choose the abema. And this person who's got a gut problem, then we may choose the other things. So with that, I end this panel discussion. I think we have got fantastic choices. Now, I want to deviate from the usual meetings and just to wake up people that, we've been giving the mementos physically whenever we meet, and we thought we'll give a digital memento, Dr. Shahina. And I think it's been a wonderful discussion by you here.
Thank you.
And we thought, because everything is virtual, and the way this the COVID situation is going, this virtual situation is going to stay for a long time. Second wave is catching up in Europe, in India, and all over the place. So our travel, our meeting physically would be different. And then we just want to thank you for this. And I must tell you that because of your name and because of your fame, we've had fantastic registrations. I think the panel, I mean, all the speakers who have been here, we've had a record of 8,000 registrations. And even now, I think 800 people are watching the whole deliberations. And I think that's because of the faculty like you and their fantastic deliberations and the fantastic academic piece. So with this, we'll try to send you the digital one again. Thank you very much. Thank you to all the panelists. And then we'll all go for the next panel. Over to you, Dr. Mansi and Dr. Parneet.
Thank you, sir. Thank you. Thank you so much. Wonderful discussion we had. Thank you, Dr. Amit. Thank you, Dr. Ashish, Dr. Rangarao, sir, Dr. Sandeep Goyale, and Ma'am Shaina, ma'am. Now I hand over the dais to my colleague, Dr. Mansi Chauhan, for 2 panel discussions that we're going to have on breast. Over to you, Dr. Mansi.
We have 2 very interesting panel discussion lined up. Thank you so much for the patient listening. I would like to invite the chairperson.
Sorry, ma'am, just one more thing. I'll request all the delegates and the panelists to please be there on the next 2 days also for more invigorating sessions that we follow. Nice sessions we have. You can go through the brochure and please be there. Thank you. Thank you, ma'am. You can continue.
Very rightly said, Dr. Parneet. We have very interesting program lined up for the next 2 days as well. Please go through the agenda and kindly join for the next 2 days as well. So moving on, let me invite the chairpersons for this session. Dr. Professor Hemant Malhotra. He is Director Oncology Services, Shriram Cancer and Super Speciality Center, and Head of the Department Medical Oncology, Mahatma Gandhi Medical College Hospital, Jaipur. Welcome, sir. We have with us Dr. Shyam Agrawal. He is Consultant Medical Oncologist from Navodaya Cancer Hospital Clinic, Bhopal. Welcome, Dr. Shyam.
Thank you very much, Garima. And Shyam, with your permission, I will open the session.
Yeah, please.
And you can take on later on.
Please.
So on behalf of the chairpersons for this session, Dr. Advani, my teacher, my mentor, and my very dear friend, Dr. Shyam Agrawal, I'd like to thank the organizers, particularly Colonel Rangarao, for this opportunity. It's indeed a pleasure and privilege to be chairing these two back-to-back panel discussions. And I would also like to make a comment that we've had a wonderful talk by Dr. Shahina. You know, with the availability of the three CDK4/6 inhibitors, there's been a lot of competition in the pharma sector, and there have been lots of talks and, you know, international speaker programs and sessions on these CDK4/6 inhibitors. But this is one of the best talks I've heard, a very balanced talk. So Shaina, thank you very much. I may also like to add that with your new hairdo, you're looking even younger and fitter. You're looking like a college girl. So
Thank you.
thank you very much for a wonderful talk.
Thank you.
So let's not waste any more time. We are running a little late, and it's a pleasure and privilege for me to invite a very well-known medical oncologist, Dr. Jaideep Ghosh from Kolkata, sorry. And I would like to request Dr. Jaideep to take over, conduct this panel discussion, and invite his panelists. Thank you very much, Jaideep.
Thank you, sir. I'll just share the screen. So I won't take much of your time because we are already late and most of the things have been nicely discussed. So I'll just straight away go to the questions. And I think we have Dr. Seema Gulia, Dr. Naresh Somani, and Dr. Shaina Daud as my panelists because the other speakers could not join. So moving ahead, we all know that with the usage of CDK4/6, the PFS have significantly improved. And this is, in short, the comparison of all the trials that we have for the first line. For the postmenopausal, we have the Paloma 2, Monarch, and the Monalisa. And for the pre or perimenopausal, we have the very focused Monalisa 7 trial. Now, what I want to mention here is, if we look at the overall survival outcomes that have been reported, only the Monalisa 7 have come up with the overall survival, which comes to 58 versus 48 months. But none of the other trials have actually come up with the overall survival as of now. I'm sure we'll get those in recent times. And if you look at the real world evidence of overall survival, Palbo has definitely shown a real world improvement in the overall survival compared to standard of care. And this has also been noted in the second line trials in combination with fulvestrant. Although palbociclib did not show statistical significance, but there was a numeric improvement. But in case of the abemaciclib and ribociclib, there was statistically significant improvement in the overall survival. So coming to the questions, so the first question would be maybe to Dr. Seema Gulia. Would you choose differently based on the efficacy, or you think all the three drugs are same?
Yeah, hi Jyoti. I mean, if you look at all the trials, maybe it in the first line setting or in second line setting, the efficacy of all the three CDK4/6 inhibitor is same. There is no difference in efficacy. So there is nothing to choose based on the efficacy. And as Dr. Shahina has also very nicely shown in her talk, that the choice of CDK4/6 inhibitor will particularly depend upon the patient-related factors, like what baseline comorbidities patient has, as well as the disease-related factor. Like any patient who has brain metastasis, probably I would choose abemaciclib rather than ribociclib or palbociclib.
Right. Thank you. So yeah, as you rightly pointed out, patient profile is very important for drug selection. So my question to Dr. Somani would be, would the previous treatment help you decide the regimen, or it's okay for you for any of the drugs?
Yeah, the previous treatment probably will decide the partner hormone therapy for the CDK4 inhibitor, whether it's the letrozole or anastrozole, or whether I want to give the fulvestrant for that matter. So that is the one thing, and maybe that a little different from the topic that if the limited meds are there, limited bone mets are there, then maybe that I will be choosing only the fulvestrant. So that is the one options, different from this particular talk. Otherwise, probably no much difference. But obviously, if the CNS mets are there, then inclination, as just commented by Dr. Seema, that inclination will be towards the ribociclib.
Right.
Not ribociclib, sorry, abemaciclib.
Dr. Shahina, I would like to know, would you use anastrozole along with? Because I think we all know anastrozole, letrozole are the same thing, but the patient assistance program is not available with anastrozole in our country. So any comments on that?
So for me, I don't differentiate between the three AIs. I think you could use aromasin, anastrozole, or letrozole. It does not really matter. What you choose, like the previous faculty just said, is depends on what you've chosen previously in terms of how you're going to combine it with combination endocrine therapy. So I do not differentiate. I think it's the same story of AI and CDK4/6 inhibitors. I think all three are equal in the AIs, and I think all three are equal in the CDK4/6 inhibitors.
And is there any particular subset where you might consider avoiding CDK4/6 inhibitors?
Absolutely not. I think the FDA meta-analysis is very, very clear that there isn't a patient subgroup that does not benefit from the use of a CDK4/6 inhibitor. So if finances is not a problem, then everybody should be getting a CDK4/6 inhibitors. However, there are those subgroup of patients who have like one bony met, who are elderly, or who have a disease-free survival of say 20 years, and then they come up with one bony metastases. You have that conversation with the patient saying, strictly speaking, there still is an advantage to using a CDK4/6 inhibitor. However, it's also acceptable if finances is an issue to use single agent endocrine therapy in those patients. But in general, you should be using CDK4/6 inhibitors for everyone if finances is not an issue.
Right.
Hi, Jodip, can I ask a question? Yeah, this is for Dr. Shahina Daud. So if there is some upcoming data that patients who have high level of cyclin E1 level, probably those are the patients who have inherent resistance to CDK4/6 inhibitor. Do you have any experience in that area? And do you think that it can be a marker in future?
I think that is research that is ongoing right now. I'm aware of that data. However, it's not something you can do practically in the clinic. You can't pick and choose your patients based on that. The test has also not been standardized or prospectively validated. It's all based on retrospective data from samples that were collected from the Paloma 3 as well as some of the other trials. I think we have to wait and watch. So far, none of the biomarkers have allowed us to say who is resistant and who is not going to be resistant to CDK4/6. And this one is specifically, it's an interesting biomarker, but it's not ready for clinical use. Right now, we just have to pick and choose based on clinical factors.
Yeah, thank you.
Right. And my question to Dr. Seema would be, ma'am, in some situations, we do face a patient who has a grossly deranged LFT, and most of the drugs are actually hepatotoxic. So would you be comfortable using chemotherapy in such patients if we go by the definition of visceral crisis?
Yeah, so it depends upon how much the organ functions are deranged, and if the patient performance status allows. So only on the basis of derangement of liver dysfunction, that is not the only factor that I will take into consideration for deciding the type of therapy to be given to the patient or whether patient can afford chemotherapy or not. So quite a few patients I have treated who had significant hepatic dysfunction or organ dysfunction, and starting them on low dose chemotherapy, particularly the weekly paclitaxel, I have seen that patient have responded beautifully.
Right. Dr. Shahina, what is your take on the use of CDK4/6 in patients who are borderline visceral crisis and not exactly the typical ones that we see?
So in my mind, I think the definition of visceral crisis needs to be changed. I don't think it applies anymore in 2021. I think visceral crisis is a spectrum. At one end of the spectrum, you have where the patient's just tipped over and the enzymes are above a certain level, for example, in the liver, or the patient is short of breath due to lymphangitis. And at the other end of the spectrum, where the liver function is so grossly deranged that even if you gave chemotherapy, that patient is not going to do well. Personally, if someone were to ask me my opinion, I think it's acceptable to actually use CDK4/6 inhibitors in that other end of the spectrum. I've done it quite a few times. It's not part of standard of care, which is why I didn't mention it in the satellite symposium, but this is now a more academic discussion. I have a lot of patients who've got pancytopenia due to bone marrow infiltration, patients with liver metastases who are clearly in visceral crisis but have refused chemotherapy. And the minute I've started CDK4/6 with endocrine therapy, they respond beautifully. And I find that, the results of the response and the probability of the response is probably similar to chemotherapy. 50% of them will respond and 50% of them will not respond. And some of them will just do badly irrespective of what you give them. So I do think that there is a role. We just have to wait for that data before we make a recommendation across the board. I think each patient has to be individualized based on what you see in the clinic, based on their performance data, and based on what the patient wants at the end of the day.
Dr. Jaideep, can I add the one comment here? Yeah. So I do agree that sometimes the visceral crisis is that much that even patient is not fit for chemotherapy. And I also have the similar experience of giving the CDK4 palbociclib with the letrozole, that they do respond and come out of the visceral crisis.
Right. Yeah, I think the visceral crisis definition was not meant to decide CDK4 versus no CDK4. It was meant for a different reason altogether. We are just extrapolating the definition of visceral crisis. So moving ahead, Dr. Shahina, we have a variable OS data, Palbo failed, Abima and Ribo passed. What is your thought on the difference, although the hazard ratios are exactly the similar?
So first thing is Palbo did not fail. The clinical trial is very different from Abima and Ribo. In the Paloma 3 trial, these patients were more heavily pretreated. They had a good percentage of them had received prior chemotherapy. A good percentage of these patients had multiple lines of endocrine therapy and had truly endocrine resistant disease. And so when you looked at those subgroups, those patients who had responded to prior endocrine therapy, they tended to have that overall survival advantage. But those patients who had just run out of options and who were resistant to everything, they didn't respond in terms of overall survival to the palbociclib. So I think you need to look at that data in that context. I think Abima and the Ribo trials were very well-designed trials to actually answer that question, because those were truly endocrine resistant second line patients or primary endocrine resistant patients. And it shows that CDK4/6 inhibitors work in that group. So I think it doesn't matter whether you use Palbo, Abima, or Ribo, it does work in that endocrine resistant cohort. I think there's an overall survival advantage probably with all three. It just hasn't been proven with Palbo. What I like about Abima is that they went back and they looked at even that really hard to treat cohort of patients, those patients with liver metastases, those patients with high-grade disease, PR-negative disease, and that 26% of patients with primary endocrine resistance where they are going to do very badly, and still it works there. So I think we need to look at it into context.
Right. And yeah, I think this has been nicely answered by you, that the Palbo has actually catered to patients who have been previously treated heavily compared to Ribo or Abima. So although there is a statistical significance in Ribo, but definitely the numeric improvement in Palbo is as good as the Ribo Abima. Now, we have had a fantastic discussion on the side effect profile, as I'll just revise through it. Definitely the QT prolongation was not recorded in the Paloma trials, but it was there in the Monarch ribociclib and the abemaciclib trials. Again, Abima did not have a much strict vigilance of the QT prolongation. And if you look at the GI symptoms, definitely diarrhea, abemaciclib has got the major incidence of diarrhea compared to Ribo and Palbo. And similarly, the liver function abnormalities were more with Palbo and Abima compared to Ribo. So if we look at these side effects, so for patients who are having an underlying rhythm abnormalities, is there any specific agent that you should avoid? Maybe Dr. Naresh can answer this, because what I'm trying to understand is the Ribo trial had a very strict monitoring of the QT prolongation, which the other trials did not probably. So just that we have the data with QT prolongation, would that provoke you to avoid this drug for patients with underlying rhythm abnormalities?
Yeah, but I had been the part of the ribociclib trial also, and I have faced this problem. So especially those patients who have the pre-existing hypertension or ischemic disease and on some treatment, probably they were having it more and probably were suffering the symptomatology more. So obviously those patients I will be more skeptical, and then the drugs like itraconazole or other similar drugs, I would like to avoid, especially when the ribociclib is there, because these drugs may have the interaction and may prolong the QT interval further. So it's very, very important to watch this, because this may lead to the sudden cardiac death.
Right. Dr. Seema, ma'am, what is your take on the pro-diarrheogenic effects of abemaciclib when we are talking of patients of our country where we know that diarrhea is a major problem, like with capecitabine, we have so many patients with grade 3-4 diarrhea.
Yeah, so as others panelists and faculty before me also described, that we have not seen diarrhea so common with abemaciclib in Indian population as compared to the Western population. And same is my experience. I have not reduced dose for diarrhea as a side effect. And if there is a diarrhea, then antidiarrheal do work well. But definitely, I have seen fatigue commonly with abemaciclib, and I had to reduce the dose to 100 milligram for fatigue.
Right. And ma'am, for the data on single agent, we have the data for abemaciclib. We do not have for palbo or ribo. But do you think that these the other two drugs will be acting differently when we are giving it as a single agent, or you would stick to abemaciclib only?
We have data for this single agent use only for the abemaciclib. We do not have data for palbo or ribo. So I won't be comfortable in using ribo or palbo as a single agent as compared to abemaciclib.
Right. And my last question to Dr. Shahina Daud would be for CNS disease, just by going with the data, you'll be using abemaciclib, or you're okay replacing it with a ribo or palbo?
No, I think at least for CNS disease, the data is, in my mind, stronger for abemaciclib. So I do tend to use it mainly for abemaciclib. But if I'd like to go back to a couple of points over here. In terms of rhythm abnormalities, QTC prolongation is specific for ribociclib, but even the incidence, if you look at real world data, is much higher than what is reported in the clinical trial. So you have to be super, super careful. And in terms of diarrhea, I completely agree. I think our population is not as bad for diarrhea. The Asians are not as bad as for diarrhea compared to the Western population. In terms of single agent, there is data for palbociclib single agent, comes from the TREND trial. It's not approved as single agent, but the data is there if you wanted to use it. But I think the data is much stronger, obviously, for abemaciclib because also being FDA approved.
Right. So with that, if there are no further points to discuss, I'd like to conclude the panel discussion. Thank you so much.
Thank you very much, Dr. Jodeep. I've got one concern, like question from the panelist. Have ever been somebody switched over from one CDK4 inhibitor to another in view of toxicities or other? Anyone can answer that.
I actually have changed over. I had a patient who was on palbociclib and letrozole, and unfortunately, that patient crashed and had grade 4 neutropenia and thrombocytopenia and developed febrile neutropenia, which I'd never seen with a CDK4/6, and ended up in the ICU. She completely refused to go back and even to reduce the dose, because I think all you needed to do was to reduce the dose of palbo, but she was too scared to go back onto palbo. I put her onto abemaciclib and she did very well, but even with abema, I reduced the dose. So it's not that I think that palbo didn't work or she would have not tolerated it. She would have tolerated it with a reduced dose, but when that happens and there is a fear, then you need to shift over.
So Dr. Shyam, I have the similar experience.
Yeah,
but
Dr. Paresh, you have
in the
written
reverse
something
way.
on chat box.
Ribociclib patient with a QT prolongation. In a responding patient, I changed to the palbo. Patient responded well and continued to respond.
Okay. That's great. That's great. Thank you very much, Dr. Joydeep, for finishing it on time. And now it's my great privilege to introduce our next moderator, Dr. Senthil Rajappa. He is the Senior Consultant from Indo-American Cancer Hospital and Research Institute, Hyderabad. And he is really a fantastic moderator you will enjoy. But being a last batsman with the limited balls, I think we have to score a maximum, Dr. Senthil. Please go ahead.
Thank you very much, Dr. Shyam. Can you please let me share my screen?
Yeah, please.
Please go ahead,
so,
sir.
Meanwhile, I will name for the moderator you have, like Anshuman Kumar from Delhi, Anushil Munshi from Delhi, then Ethan Dang from Mohali, then Chaturabhuj Agrawal from Delhi, and Deepti Pawar from Patna,
and Mridul Malhotra from Gurgaon, and Dr. Tabassum from Mumbai, and then Dr. Sumantra Sirkar from Patna. This is all your team. Go ahead, Doctor.
Correct. I have my team, but I don't have my screen. So.
Oh, so pitches is still not ready.
Correct. Correct. I think
Yeah.
it's not ready for the tiebreaker, tail ender, whatever you want to call it as. Yeah, there it is. Fine.
Yeah. Yes, sir.
Great. Very good. So I won't take too long. I'm going to stop in 20 minutes because it's bedtime for me.
Yep.
So I hope Dr. Rangarao sir will not mind. Okay. So I think the topic for today's panel discussion is unmet needs in triple negative breast cancer. So there are too many unmet needs, but I just thought I'll start with a case. We'll stop in 20 minutes flat so that everybody's back to their dinner table or bed, wherever they belong to at this time. 40-year-old lady, left breast lump and bilateral axillary nodes. You can see that very obvious on the PET CT scan. There's no family history of cancer. She's a 40-year-old lady. A mammogram and an MRI was done. It clearly showed the left breast lump, as you can see here, and bilateral nodes. There wasn't a primary that was seen in the right breast. You see that there's a lymph node there. You don't see a primary there. The same was the finding on the mammogram and the MRI. So our diagnosis was carcinoma of the left breast, clinical T2N1, M1 because of the opposite axilla being positive in the mammo and MRI being negative. The pathology was invasive ductal carcinoma, grade 3, triple negative on both sides. So let me start with the surgeon. I didn't see Dr. Sumanta and Dr. Anshuman on the list. So if they are there, please let me know. If they aren't, let me still start with the surgeon. Dr. Deepti, what would be your approach? Would you call this stage 4 or you would call this TXN1 on the right side? What would be your thought?
Sir, I'm a pathologist, sir.
Oh, great.
Not a...
I'm so sorry. They listed you as, okay. So can you help us dissect through this problem from a pathology standpoint? Is it possible to tell us, is this a second primary on the right side, which is occult, versus telling us that this is a metastatic disease? Is it possible for you to resolve that issue? Difficult, I suppose.
Like, I don't know how to differentiate.
Very good. I also don't know, so it doesn't matter. Anushil, I saw you on the screen, so you take that. Is this occult primary versus stage 4?
Well, since you have revealed one triple negative disease, so I would actually go in favor of metastatic disease, given the fact that MRI is negative, everything else is negative for the other breast.
Right. So this is the 4th negative after the triple negative, I suppose. Never mind.
Even I concur with Dr. Anushil. I think it is a case of metastasis to the opposite side.
Very good. Very good. Thank you so much, Dr. Tabassum. So let's start. Let me get back to, Anushil. Anushil, intent of treatment in this patient, oligometastatic triple negative disease, palliative, curative, not sure, decide on the go. What would be your thought?
So I would take one step at a time.
Okay.
And my feeling would be that we should, obviously triple negative disease, contralateral node. So begin with chemo and then take a call subsequently as to how the situation unfolds.
Okay. So you're on the not sure, decide on the go group.
Yeah.
Right. Very good. Dr. Chaturbuj, palliative, curative, not sure.
So
can't hear you properly, Tachur. Yeah, go ahead. Okay, Dr.
Sorry,
Ketan.
sir.
Yeah. Go ahead, Chaturbuj. Go ahead.
Sorry, I just missed that one part. Whether the right-sided lymph node biopsy was done or not. To confirm
biopsy was done. It's also triple negative.
So both triple.
Yes. Can't hear you. We are losing you. Okay, we've lost Chaturbuj, it looks like. Dr. Ketan? Is Dr. Ketan around? If he's not there, Dr. Mridul?
Although stage 4, sir, but taken as oligometastatic,
okay.
would consider it as a neoadjuvant intent. and reassess after completion of dose dense AC followed by taxane.
Okay, very good. Dr. Tabassum, you have shown clearly in your randomized study that this should be treated as stage 4, of course, and there is no need for any loco-regional therapy. So let's say this patient achieves a clinical and a metabolic complete response after neoadjuvant chemotherapy. Would you send it to your surgical colleague, or would you say, no, I will not operate? What would be your approach?
Yeah, I concur with Dr. Mridul. I mean, I would be keen on treating her with curative intent, and especially if she has responded. So I would definitely send across the patient to for surgery.
But isn't there lots of evidence now to say that patients who are stage 4, there isn't a role for loco-regional therapy? And includes your own study published from your hospital. So why would you think differently in this patient? And this is an aggressive disease. In fact, the latest study that was read out at ASCO this year showed that there might numerically be a detriment for patients with triple negative disease who have loco-regional therapy. So why is it that this is different?
I mean, this per se, if you regard this patient as an oligometastatic, if you consider this as an oligometastatic, then there is evidence that patients who, if they are treated with curative intent, they do well. Of course, oligometastatic patient who is not yet spread distantly will definitely behave better than the patient who is disseminated everywhere.
Okay, great. So we agree with that point. You have a valid point.
I have a small comment.
Yes,
how much sure we are that it's definitely a palliative setting? So I mean, she's a young lady, 40-year-old, triple negative. There is no intermediate mediastinal node. Means there are two steps. So it could be very well two separate primaries. So once we have achieved the complete response, so I think that we should give the benefit of surgery to the patient. Means it's not like that clear cut.
Agreed. Because there is no one correct answer in this situation. In fact, Vivek has made a very important point in the chat box saying that oligometastatic patients were never a part of these studies. I agree with you, Vivek, especially patients who have one site of oligometastatic disease. They were not a part of any of these studies that have been published. So I think these are patients in whom you have to take a decision on a case-to-case basis rather than extrapolate findings from these studies which have looked at loco-regional therapies. So, of course, as was pointed out by Dr. Mridul, we did dose dense AC followed by Taxol. Is there any role for carboplatin here, Ketan? Ketan is not around. Chaturbhuj, would you use carboplatin here?
So yes, sir, I would like to use, because she's triple negative, I would like to also know the BRCA status, and I would like to use carboplatin combination in combination with taxane once I finish this anthracycline.
But is there good data to say that carboplatin should be used in all patients?
No, I truly agree that there is no data, but already we know that triple negative is very much platinum sensitive, and in this disease, when we are already contemplating surgical modality after our neoadjuvant chemotherapy, so I would like to achieve the best response.
Okay, so you're just interested in that responses in order to see whether you can subject this patient to loco-regional therapy. Very good. So this patient had a clinical and metabolic CR on, and of course, on the PET-CT after neoadjuvant treatment. So she underwent a wide local excision and bilateral axillary lymph node dissection, and lo and behold, it was pathological complete response on both sides. So Dr. Tabassum, adjuvant radiotherapy on both sides, or?
So, because I am considering the opposite axilla as the oligometastatic site, and if that has been addressed with surgery and there is a complete response there, so I would offer radiotherapy only to the ipsilateral side, the lymph nodes and the breast.
But conventionally, Anushil, let me ask you what you would do. Would you do radiotherapy to the opposite axilla also, or would you not? Because my understanding is that if you're chasing the oligomet, you better really drive it home or drive it out, whichever you want to call it. That's my thought. In fact, that's what we ultimately did. But what is your feeling?
So you're absolutely right. Chase it down, and you have chased it with surgery.
Correct. We've chased it with surgery. You don't need to chase it any further, you're saying.
You don't need to chase it any further. You have done the job as surgery. Left side, give RT.
Okay.
Yeah, because it will increase the lymphedema rates drastically.
Very good. So the right side does. So let's say, for example, this was ER positive and you had a solitary bone met. Would you radiate that bone met, or you wouldn't radiate that bone met? You would radiate it if surgery was not done. That's the point you're trying to make.
Yes.
Very good. Excellent. Yeah. So, of course, we did discuss it in about tumor board, and then the radiation people felt that it might be worthwhile radiating the opposite axilla also. So this lady did have axilla radiation on both sides, maybe over treatment, but of course, there isn't one good answer as we have been discussing through this case. So oligometastatic triple negative, I think, is one area where we really don't have good high level evidence to say what is the best way to manage this particular clinical situation. We will move on to our next case. This is a 35-year-old lady with locally advanced breast cancer, married a year ago. Oh, sorry, it's not locally advanced breast cancer. That's an error. So she was married a year ago, breast lump on a screening mammogram. And the screening mammogram was done because she was anxious as her mother had breast cancer and she died of it. So on the screening mammogram, a 0.8 centimeter lump was detected by BI-RADS 5. There were no nodes. Is there any additional imaging that you would want to do, Anushil? Anushil? Dr. Tabassum, if Anushil
Yeah,
is not.
I think at the 35 years age, I am not sure how effectively, I mean, a 0.8 centimeter tumor has been picked up on a mammogram. The radiologist has done a very good job, but still considering the breast would be dense, it would be worthwhile to do an MRI, and also in view of her family history, it would be advisable.
Advisable to do an MRI and of course do the BRCA also. Okay,
Yes.
Image-wise, that's right. And you wouldn't do a metastatic workup for this patient, right?
No, it would be guided by the, I mean, the extent of disease. If there are no lymph nodes, I would not be keen to do metastatic.
Fine. So this lady, though, didn't have an MRI, but of course she had a sonogram, which also picked up the same lump, which is something that we use in patients who are young and who have dense breasts, because that was done. And of course, this lady ultimately underwent a wide local excision with sentinel lymph node biopsy. This was the pathology. 0.6 centimeter, no lymphovascular or perineural invasion. Margins were negative, and the sentinel lymph nodes, of course, were negative. Chaturbhuj, what is your choice of adjuvant therapy for this lady? 35-year-old T1B, triple negative.
So, sir, she's young and it is T1B, so it is no negative adjuvant therapy. So, I would like to give her an anthracycline taxane-based combination, most likely dose dense AC followed by taxane, which conventionally we use because it's triple negative.
Right.
Can we know the IHCs?
Triple negative.
Okay.
Triple negative.
Triple negative.
Yeah, okay.
Triple negative. Right. Ketan?
The 4TC.
4TC. Mridul?
4TC, sir.
4TC. So why would you do 4TC instead of doing AC dose dense and T dose dense, Mridul?
Sir, young patient, she's T1B only. So less than 1 centimeter, more than 0.5 to 1 centimeter, we can, basically she's low risk, node negative. So we can spare the anthracyclines, which can have problems in this young patient.
Is there anything called as a low risk triple negative, Mridul? I don't know. I'm just asking you that question since you used that phrase.
So size less than 1 centimeter, node negative TNBC.
Chaturbhuj, how would you defend your decision to give dose dense AC and taxane?
So I think, sir, you answered my question already, because
okay.
I don't think there is nothing like dose low risk triple negative. So triple negative, if they recur, then we don't have anything. So I would like to hit triple negative best with my best agents in the adjuvant setting.
Okay, very good. So I think this is another area which is gray. This is an unmet need because this is a rare situation. So we don't have really large volumes of randomized patients between this chemotherapy versus another chemotherapy in order to decide which is the best way to go forward. NCCN will say that you have to give AC dose dense, taxane dose dense for all patients as long as you decide to do adjuvant chemotherapy for them. But if you look at the ESMO guideline, I think both both Ketan and Mridul are actually correct in a way that TC 4 cycles is also a choice. They think AC 4 cycles is not an appropriate choice, but TC 4 cycles would be one of the chemotherapy of choice in this patient with a T1B 0.6 centimeter with negative margins. Anushil, radiation therapy, anything in particular? Are there any controversies in a situation like this? I don't know. You can enlighten us.
So there is no controversy. Breast conservation is radiation has to be given.
Right.
And the recurrence rate, local recurrence rates, fortunately, even in triple negative scenario with breast conservation and local radiation are almost the same as in a non basis.
Very good. So we would certainly subject this lady to radiation therapy also. So what we did was dose dense AC and T followed by radiation therapy. Of course, she's on, screening and surveillance protocol with mammogram and an MRI every 6 monthly. So that's what is happening to this patient. Right, we move on to the third case, 55-year-old right carcinoma breast, T2N1N0. The breast can be conserved even if you want to do upfront surgery. The biopsy is grade 3 invasive ductal carcinoma. The ER is 3, PR is 4, HER2 is negative. So, Chaturbhuj, neoadjuvant therapy or surgery now, breast can be conserved.
It's a very tricky question, sir. So,
not a question at 9:45 in the night, isn't it?
So I would like to go ahead with surgery first. Because
you would like to go ahead with surgery first. So let me bring in our pathologist.
Why not? Sorry, from a radiation oncologist.
No, go ahead, Anushil.
Why not chemo first and give it a chance of sentinel subsequently?
Give a chance of sentinel subsequently. So let our medical oncology group tell them why we should do neoadjuvant versus not. Anyone can take that question. Chaturbhuj, Ketan, Mridul, any one of you.
So I think, sir, if it would have been a hormone negative cancer,
that would have been a no-brainer, isn't it?
And even because you have so much emphasized that breast can be conserved even with upfront surgery.
Correct.
So that's something like you are giving me a clue that I have to answer that surgery now.
You are very brilliant, I say. So you would have passed with distinction in your exam, I suppose. Dr. Tabassum, what would you do in your hospital when a patient like this is there? This is ER poor, PR poor. So we all know that 1% is positive, but all of us will on the contrary say this is a patient who's behaving or rather likely to behave like a triple negative cancer, not like an ER positive cancer. So what is your approach at Tata Hospital, Dr. Tabassum?
Generally, we would not subject a patient to neoadjuvant chemotherapy if the patient is operable upfront. So,
irrespective of the phenotype, let's say if this was ER 0 and PR was 0?
No, not irrespective of tumor, but especially patient who is ER positive and HER2 negative.
Okay. So you're saying... Okay, so you are saying that this patient's clinical behavior is likely to be very similar to an ER-PR positive. Is that what you're saying? No, that's acceptable because we still don't know. This is again a rare group.
She's sitting on the fence. She could be this way or
correct.
That
she
way.
Could fall this way or that way, right? So this is again a very tricky area. So our way of approaching a patient like this is that you approach it like a triple negative and then finally add the hormonal therapy. That's how I usually approach a situation like this, because all of us know that when it is less than 10%, it becomes a little daisy. Let me bring in our pathologist. Madam, can you throw some light on this situation? ER is 3%, PR is 4%. What would be your guidance to us in managing a situation like this from a pathology standpoint?
I think it's ER, PR, both positive. You can try with the hormonal therapy. So it is positive, right?
Okay. So you're saying it's positive, so it's positive. So be positive in the midst of all the triple negative.
Yeah.
Okay, very good. So this lady underwent EC4, T4 dose dense followed by wide local excision, sentinel lymph node.
You did give sentinel, you did give neoadjuvant.
Pardon me, Manushil?
I said you did end up giving
Yeah, correct. So we followed your pathway. Correct. That's why I said in our hospital, when somebody is ER poor, we treat them more like a triple negative rather than an ER positive. So we did do a sentinel lymph node because the lymph nodes, the N1 had actually disappeared after the therapy. So let's come back to the medical oncology friends. YPT1N0, Chaturbhuj, create X or just tamoxifen?
Sir, it's again, so I would like to correct myself. Actually, when I said surgery, my intention was it was year 3/8 and PR 4/8.
No, it's 3 and 8.
3 and 8.
And 3% and 4%, whatever.
So definitely it is neoadjuvant chemotherapy followed by surgery.
Fine, no problem. No problem.
So
we'll stand corrected. Now, what would you do, Chaturbhuj? YPT1N0, adjuvant therapy, create X versus hormones only.
I think since we have already realized that she is a triple negative sort of cancer, so I would like to give her a capecitabine based adjuvant therapy followed by maybe hormonal therapy.
Okay, so you would finish 6 months of capecitabine and then follow it up with hormonal therapy. Good suggestion. Ketan and Mridul, would you agree with Chaturbhuj?
So I would discuss regarding capecitabine and create X data with the patient. If she agrees, then go ahead.
Okay, she agrees. You will go ahead. So Mridul, would you also agree with Ketan?
Yes, sir.
Very good. So that's what I did. In fact, I started the tamoxifen along with the capecitabine, though there is no clear data. In fact, there is some data that the adverse event profile in a situation like that might actually be a little worse. But fortunately, this patient tolerated it. 6 months of capecitabine was over, and then the hormonal therapy is actually going on. So this is another gray area where we really don't have clear, good answers as to how do we go about managing. Do we have time for this case, or can we stop? It's 20 minutes down. Doctor,
we have got eight more minutes, Dr. Senthil. Hello.
Do you want me to torture you for 8 more minutes?
Yes. Go ahead.
You want to continue to be tortured? Torturing nicely. Very good. It's like triple negative, right? Okay. 27-year-old lady, no family history of cancer, right carcinoma, breast T4B, N1, M1, grade 3 ductal carcinoma, triple negative, had dose-dense AC Taxol, MRM, radiotherapy, and then BRCA is positive. 12 months later, comes back with liver metastasis. And this is the scan. What you're seeing is what the scan was. There's a huge met, rebiopsy, triple negative, PDL1, SP142 is 0, liver function, 3-fold elevation in SGOT and ET. What do we, and this is her, report. Of course, this is on the tumor block that was done, not on the blood. So the BRCA is positive. Chaturbhuj, what would you do to a patient like this? 1 year, exactly a year after completion of adjuvant therapy, liver is studded with metastasis, something like the visceral crisis that they were discussing in the earlier panel discussion. So germline BRCA is positive.
So, sir, I think I would start with a weekly taxane sort of therapy because this is a visceral crisis sort of situation. But on the other hand, most of our agents are we are already short of agents. So either a weekly platinum or weekly taxane. But I would prefer a weekly taxane.
Mridul, is there any role for single agent carboplatin in a patient like this? Mridul, are you around?
Yes, sir. Yes, sir.
Go ahead.
So, single agent carboplatin can be used, but looking at the disease bulk, I think I would prefer to give a doublet, maybe weekly pacli carbo to begin with.
Weekly pacli carbo. Yeah. Very good. Ketan, weekly pacli carbo.
So we have data to show that carboplatin is at least as efficacious as docetaxel in this setting. Since the patient is you said impending visceral crisis, so I would prefer chemotherapy. Otherwise, without visceral crisis, I would have chosen a PARP inhibitor. And given the agent, carboplatin is at least as effective as dosi in this setting. So maybe a single agent.
Okay, so let me tell you the data, and then you can maybe have a rethought at what you are suggesting. So when you look at the TNT trial for patients who had a BRCA that was germline positive, the response rate to single agent carboplatin was 68%, which is a whopping 68%, I should say, which is much more than the taxanes and all the other drugs that we use. And in a situation like this, where the liver is not at its best, it's not wrong to use a doublet, perfectly all right. But would any of you be comfortable using single agent carboplatin based on the TNT data? because all of us keep talking about this TNT data again and again and again, but none of us would dare, should I say, to use single agent carboplatin, and none of us includes me also, Ketan. So why is it that we actually turn our heads away from this lovely single agent data? I don't think you will get a data like this again. So is it just
since we have
discomfort? We don't
DFI
believe
more
it?
than 1 year?
Okay. Okay, DFI of more than 1 year, so you want to use, a taxane again in that situation. Chaturbhuj, single agent taxane, would you be happy with it? I mean, it's one of the choices, certainly agreed, but would you be happy using a single agent taxane in a patient like this who's not at her best?
Sir, yes, sir. I would definitely be happy with. In fact, a single agent taxane is my first choice in this case.
Okay.
But at the same time, I would like to add platinum if the AST/ALT goes down. If I can see some response, I would convert it to doublet.
Okay. Okay. So you would use carboplatin if the AST/ALT actually started going down. Okay, we could discuss that. I would actually, intuitively think that if things are getting better, why would I want to use a second agent? But never mind. You can use that single agent. I mean, you can use that second agent also in a situation like this. That's perfectly all right. So the question of the PARP inhibitor actually came. I think Ketan or Mridul, one of you made a point saying that if the liver functions were not deranged, I would have used a PARP inhibitor. Why is it that you want to use a PARP inhibitor upfront in this patient? Ketan or Mridul, whoever said that.
Yes. When the patient is not in visceral crisis and we have some time to buy, then a PARP inhibitor is also a drug of choice.
So is there any advantage to using a PARP inhibitor early, Ketan?
Yes, sir. Probably we have some data to show that, but
that you are actually correct. In the Olympia study, when they actually looked at the subset of patients who took first-line PARP inhibitors, there was actually an overall survival benefit. But people sarcastically say in the Olympia, who actually took the medal? Was it the drug or the company? So that's besides the point. But most of us would be a little hesitant using a PARP inhibitor upfront, in spite of that data which is actually available. In case you want to use a PARP inhibitor. So most of us would use a platinum-based treatment in a situation like this. And then the problem is, how good is a PARP inhibitor after platinum itself? Is it likely to be equally efficacious? Because most of these trials actually excluded people who had been exposed to a platinum first. So that's the irony of the whole thing. So I would say carboplatin is the poor woman's PARP inhibitor. And in this situation, I would probably prefer to use that. Suppose, Chaturbhuj, that this lady had a somatic BRCA. Would you want to use a PARP inhibitor in a situation like that?
So my first choice would be definitely chemotherapy. But after chemotherapy, I have used, and if this lady is still somatic BRCA mutation positive, then I would, after chemotherapy, once she settled down, then maybe once this visceral crisis situation is over, then I would be comfortable in using a PARP inhibitor.
But is the data with a PARP inhibitor strong for patients who have a somatic BRCA?
So for breast cancer, somatic BRCA, I don't think the data is that strong as we have with ovarian cancer.
You're correct.
And for germline in breast, we already have very strong data.
That is correct. So if it is germline, you would probably use it somewhere down the line, or depending upon where you want to use it. But if you have somebody with a somatic BRCA, I think the data is very, very flimsy. You would probably want to use it in a desperate situation, but that desperate situation would be one wherein the drug also doesn't work, and then you will blame the drug rather than the clinical situation. That's something all of us do. So I think we would use a PARP inhibitor somewhere early if this patient was germline BRCA. Of course, this patient is a germline BRCA, so that's what it is. This is what happened after 4 cycles of gemcitabine and carboplatin. We didn't reuse a taxane. We actually used gemcitabine. So that is what is the story of this particular lady. So we still have 3 minutes to go in case you want to continue to ask a question or pass a comment. But if there is nothing,
yeah, if the patient is
go ahead.
Yeah, sorry to interrupt, sir.
Please.
So if the patient is PDL positive, PDL1 positive.
Very good. So my view, I think atezolizumab the approval should be withdrawn. That's my honest opinion, because it's not stood the test of a second exam. It's failed in the second exam, though you can find out 100 reasons to say why it actually failed, but it failed. If at all you want to use something, I would suggest that you should be doing a 22C And then if the PD-L1 CPS is more than 10, then you probably should think about using pembrolizumab rather than using atezolizumab. That's my personal opinion on this. So that's where I would put immune checkpoint inhibitors in this setting.
But if the patient doesn't have visceral crisis,
but yeah, go ahead, Ketan.
If the patient doesn't have visceral crisis and she's also germline BRCA positive, then would we prefer an atezo plus napacli or olaparib?
No, I think the BRCA status does not determine whether you use an immune checkpoint inhibitor or not, because they did look at the atezolizumab trial data, looking at tumor infiltrating lymphocytes, looking at whether the BRCA would be more predictive. None of that was more predictive than the PD-L1. But ultimately, in a confirmatory study, it actually went for a 6. The trial itself ended up being negative. So I don't think the BRCA should be a determinant of whether you use immune checkpoint inhibitor or not.
Agree. Thank you so much.
So I just wanted to make one last comment.
Please.
That this lady has a recurrence exactly after 12 months.
Yes.
So in that subset, again, we don't know whether, if I take forward the IM patient 130, so those are the patients who had a recurrence after 12 months.
That's correct.
So that we can use a taxane in combination with atezolizumab. But one definitely subset in which we are lacking is those patients who recur within 12 months. So we don't know what ideal chemo partner we can combine with atezolizumab. So I don't find it.
In fact, some people feel gemcitabine should not be the companion for an immune checkpoint inhibitor at all because it is likely to cause lymphocyte depletion, and that's not the best situation for an immune checkpoint inhibitor to work. So even in the Pembro study, patients who took Pembro plus gemcite platinum did not do that very well if you look at the forest plot, though it was not really powered to look or answer that particular question. Anushil, last word from you before we say good night.
Last word is that even in the triple negative metastatic scenario,
there's some role for radiotherapy,
yeah?
Anushil, go ahead.
Listen.
Yeah, I'm listening.
There is some encouraging data of combining Pembro and radiation.
Okay.
Early phase 2 data, where they have shown encouraging responses by use of local radiation at 1 or 2 metastatic sites.
I understand. Yes, Anushil.
So do give it a serious.
Oh, certainly. We should not forget Anushil when it comes to the abscopal effect. Thank you so much, Anushil, for that tip. They say.
So may I please just ask one last comment?
Ketan, it's 10 o'clock, Ketan.
Sorry.
So we'll hand it back to the organizers. Mridul, you want to ask? Everybody wants to talk. All of you are so fresh at 10 o'clock. I can't believe this. It's sleeping time for me.
Sir, any role of atezolizumab to use in neoadjuvant setting?
No, certainly not. Certainly not at this point.
Thank you very much, Dr. Senthil. I think
comments on bevacizumab, please.
We need to conclude now because the organizers are after me. So excellent moderation, Dr. Senthil, as always. And you have brought out so many gray areas in triple negative breast cancer. That is the excellent part of it. And thank you very much, Paras Cancer Conclave 2021 organizers, especially Dr. Ranga Rao, for inviting us for this excellent panel discussion. Thank you very much. And over to organizers.
Thank you so much.
Thank you. Thank you, sir, and good night. Thank you.
Thank you, sir.
Any closing remarks by Dr. Rao?
Nothing. It has been fantastic discussion today. We overshot time and everyone was made awake by Senthil, and then so many people watching. Actually, I was seeing the statistics all together. Almost 825 people are still watching. I think it's a wonderful audience. Very, very good. And that's simply because of the great deliberations by the great faculty that we have. Thank you, one and all. Thank you very much.
Thank you so much, and good night.
Finally, a huge thank you and a virtual round of applause for all the faculty members for the wonderful, thorough and brainstorming session about different aspects of breast cancer management. Thank you all and have a good night. And please do join us for the next 2 days for interesting sessions ahead.
Yeah. Quiz. Another information: a quiz is going on in Hall D. Anybody interested can go there. Thank you very much, everybody, speakers, the debaters, the moderators, the chairpersons, everybody. And do join us tomorrow for the other next academic feast for the next 2 days. I'm sure you will be very delighted with the agenda. Please, we look forward to meeting you all. Thank you very much. Thank you, Dr. Mansi. Thank you very much.
Thank you.
Thank you, Dr. Barney.